Novel Coronavirus Southwestern Intergovernmental Committee is called to order. Will the Secretary please note the attendance? And without objection, the committee minutes of October 20th, 2023 are approved as distributed. We do have our rules for decorum here in the Senate. I know that sometimes some of the things we talk about deserve booing and applauding, but if you could keep that to a minimum, we'd appreciate it. And silence your cell phones, please. And if you need to take a call, I just ask that you step out so that it doesn't disrupt the conversation. Thank you all for being here today. We are going to start with the introduction of the esteemed physicians that are here, and then the senator to my right, and then I will finish with introductions. Dr. McCullough, would you like to start?
I'm Dr. Peter McCullough. I'm a practicing internist and cardiologist in Dallas, Texas. I've played a role in the pandemic response in terms of early treatment and publication of protocols to help people avoid hospitalization and death, as well as the first peer-reviewed and published protocol on detoxification after the vaccines to help patients avoid vaccine complications. I have over 70 peer-reviewed papers on the pandemic, and I continue to be a voice in the mainstream as well as social media spaces. Thanks for having me.
Thank you. Dr. Hale?
Hello. I'm Steve Hale. I'm from Prescott. I'm a VA emergency room doctor as well as an intensive care doctor in Prescott at the YRMCA Medical Center. My role has been to be an advocate for patients, and therefore that would mean prescribing repurposed drugs that have not been popular amongst the medical agencies, and advocating for patients by informing them about vaccines and potential harms. So I'm on the front of, in the beginning when they come in the emergency room, and in another hospital on the back end when I see them in the ICU.
Dr. Apter?
Good morning. I'm Dr. Robert Apter. I practiced emergency medicine for 44 years and retired in 2020. In April 21, I started doing telemedicine for COVID only with a company called myfreedoctor.com. All of our consultations were free and were paid for by donation only. In that vehicle, I've seen 15,000 patients, or done 15,000 consultations for patients around issues related to COVID, including some very sick patients. And then I ran afoul of the licensing board, so I became a plaintiff along with Dr. Bowden and Dr. Paul Merrick in the lawsuit against the FDA. And I'll tell you more about that.
Thank you, Dr. Apter. Dr. Bowden?
Hi, I'm Mary Talley Bowden. I'm an ear, nose, and throat doctor in Houston, Texas. Outpatient treatment of COVID patients. I've treated now over 6,000 people. I'll give you a lot more details about why I'm here during my talk.
Okay, thank you very much. And Dr. Merrick was unable to make it today. So Senator Shamp, LD 29, I think most of you know me around here as the nurse who was fired for not getting the vaccination. But today I am also a friend of someone who recently died from the ongoing COVID-19 hospital protocols that I was told last year were not being utilized anymore. And when I was elected and serving in this seat as the chair for the NCSIC and the vice chair of the Senate Committee on Health and Human Services, this was something that I inquired about immensely. I would like to do a moment of silence for my dear friend and all of the COVID-19 hospital protocol victims from around the world. So if you would please bow your head. Oh, thank you. Hospital systems across America continue to medically gaslight and ignore the evidence presented through various congressional and state-led hearings. This astonishingly flippant attitude has prioritized expensive drugs like remdesivir while banning more effective and less costly treatments. To the naysayers, I offer this. And I will say this, these are not my words, these are words of another. that does not want to be put on the record. To the naysayers, you didn't ask for evidence when they told you to social distance. You just did it. You didn't ask for evidence when they told you to stay home for 2 weeks. You just did it. You didn't ask for evidence when they told you to mask up. You just did it. You didn't ask for evidence when they told local businesses to close down. You just went along with it. You didn't ask for evidence when they pulled your kid out of school. You just went along with it. You didn't ask for evidence when they scared you with terms like super spreader. You just went along with it. You didn't ask for evidence when they said you couldn't visit the nursing home. You just went along with it. You didn't ask for evidence when they said the funeral would have to be via a Zoom call. You just went along with it. You didn't ask for evidence when you followed the arrows on the floor at the grocery store. You just did it. You didn't ask for evidence when they promised the shot was safe and effective. You just believed it. You didn't ask for evidence when they said we meant get 2 shots to get your life back. You just went ahead and got it again. You didn't ask for evidence when they said, oh, our bad, you'll need a booster every year now. You just got back in line for more of it. You didn't ask for evidence when they said we meant boost a few times a year. You just nodded your head in agreement because look how far you've come. Can't go back now. But if someone tells you any of that was horrible and wrong and it's ruined millions of lives, you're going to need to see some evidence. Ladies and gentlemen, that is exactly what this committee was formed to do. We are here to give you the evidence to make the decisions about your health care. And with that, we're going to go to our first presentation with Dr. McCullough.
As introduced, I'm Dr. Peter McCullough. I have seen and examined thousands of patients with acute COVID-19 and managed them before the hospital phase of care and helped them successfully avoid hospitalization and death. And now, sadly, I've seen thousands of patients who've suffered injuries, disabilities, and unfortunately death after COVID-19 vaccine. The COVID-19 illness and the vaccine are very similar in that they expose patients to a protein on the surface of the virus, the spicule, if you will, or the spine on the surface of the virus called the spike protein. The spike protein was intentionally engineered in a Chinese biosecurity lab in Wuhan, China. The spike protein is not a natural protein. It's been modified by mankind in a joint US-Chinese collaboration that took years to create SARS-CoV-2. It's now fully acknowledged through the House Select Coronavirus Investigative Committee in Washington that SARS-CoV-2 was created in the Chinese biosecurity lab in Wuhan, China. And there are co-conspirators in the creation of this virus, and it's now well acknowledged that they include Dr. Anthony Fauci of the National Allergy Immunology Branch, Dr. Ralph Barrick at the University of North Carolina at Chapel Hill, Peter Daszak at the EcoHealth Alliance, who helped coordinate it all, and Dr. Xingling Li, the lead researcher in the Wuhan lab. Because the spike protein gets in the human body with the infection and in a massive dose with the vaccine, that's the reason why people feel sick afterwards after having COVID-19. We call that long COVID. Well, people feel sick after the vaccine even more so because they even have a massive dose of the spike protein in the human body. And a recent study from Germany by Brogna and colleagues has found that the spike protein is physically circulating in the blood of those who've been vaccinated, at least half of them, for 6 months or more. The messenger RNA has been modified intentionally to be long-lasting in the body. That's Pfizer and Moderna. And because so, the messenger RNA is circulating in the bloodstream for at least a month, found in lymph nodes for several months. So people who keep taking the vaccines keep building up more and more messenger RNA and more spike protein. There are over 4,000 peer-reviewed papers in the medical literature now, which is heavily suppressed, by editors and by sponsors and institutions who don't want this information to come out, but there's still 4,000. And the 4,000 show, proven beyond a shadow of a doubt, that about 70% of long COVID, as we know it, is actually caused by pre-vaccination or vaccination before or after the illness. The literature demonstrates that 4 major areas of damage to the human body are occurring. To the heart, myocarditis, an acceleration of cardiovascular disease, arrhythmias, and cardiac arrest. And yes, the unexplained cardiac arrests that you see out there are due to COVID-19 vaccination, unless it can be completely proven that the patient didn't take the vaccine. Neurologic, both ischemic and thrombotic stroke, Guillain-Barré syndrome, paralysis, small fiber neuropathy, seizures, hearing loss, vision loss. A condition called POTS, posterior orthostatic tachycardia syndrome, where patients become very unsteady and pass out. Yes, those reels of all these media people passing out on TV, that's largely POTS. The third area is blood clots, thrombosis, blood clots like we've never seen before. Blood clots that can extend from the ankle to the hip and shoot to the lungs and then are fatal. Blood clots that form in the brain and cause particular forms of stroke called central venous and cavernous venous thrombosis. The FDA agrees to and says the vaccines cause these syndromes, so it's not controversial. And then the fourth area is immunologic. The vaccines actually trigger the production of all different types of proteins besides the spike protein that incite autoimmunity. A fifth area of concern is emerging, but I think it could really be a concern, is that the vaccines could cause cancer or accelerate cancer or bring people out of remission back to active cancer. All of this has now been fully disclosed in 4 sets of U.S. Senate hearings, at least 3 sets of congressional hearings here in the United States, deliberations in European Parliament and the lower house in England. And to this day, not a single government or regulatory agency will do a safety review of the vaccines, let alone pull them off the market for lack of safety. And as we sit here today, our US CDC VAERS system tells us that there are confirmed by the CDC approximately 18,500 Americans who have died after the vaccine. 1,150 die on the same day they take the shot or in the vaccine center. 1,200 die the next day. It shouldn't have been more than 5, 10, 15, or 50 deaths. It should have been pulled off the market. Yet our CDC is openly telling us that these large numbers of deaths occur in people healthy enough to walk into a pharmacy or a vaccine center. It's grossly underreported, probably 30 to 1. That means the total number of Americans who likely have passed away of the vaccine is about 550,000. 550,000. Our 2 major presidential candidates are the same on this issue. They are completely, willfully blind to what's happened to Americans. They're focused on other issues outside of the health, the welfare, and actually the survival of their own people. The same is true worldwide. So what we're going to do today is we will do a deep dive on the data, and we'll start with what's happening in the hospital. Because what happened in the hospital and patients dying in the hospital is part of the same continuum of patients dying after the vaccine. It's all the same. It's exposure to the spike protein and then the inadequacy of public health institutions, medical institutions, hospitals, and doctors to respond to this great calamity. So what we want to do today is fully disclose to the best we can and answer questions and have a dialogue here and bring you the truth and bring people of Arizona the truth and give some bona fide next steps of what can be done to in a sense, make what's happened right to the best we can, and certainly to prevent this calamity from progressing or having a new one on our doorstep and make all the same mistakes. I'm Dr. Peter McCullough. Thanks for listening.
Thank you, Dr. McCullough. Did you want to go into any detail about the specific drugs, or would you like to do that more towards after, kind of throughout with the conversation?
Let's do it throughout.
Okay, perfect. All right. So, Dr. Apter, would you like to start with your presentation? Sure. Is that a good place to start, or Dr. Bowden, would you do you want to lead into it? How would you? You don't care? You guys are both either way? Okay. I just want to make sure that everyone understands that the information that is the wealth of knowledge that is sitting up here is extremely important to this conversation. And I hope that everyone watching and everyone watching at home and listening, that you share this. My husband is constantly saying, if one person tells 10 people, and then each one of those 10 people tells 10 people, we can get this information out there. We can make a difference. So please remember that as you're listening to this information today, okay? Thank you. Dr. Apter?
Thank you. So the title of this little talk is What is the Agenda? And I don't know if you can see slides on monitors.
Yep, yeah, they can.
Yeah, so I'm living in Sedona, and that's a picture that I took literally out my front door when we had a big dump of snow last year, and that's Coffee Pot Rock. And it's a wonderful place to live. Next slide, please. So the opinions here are solely my own. I'm not representing anybody else, and none of this is intended to be any kind of medical advice. And I said, wouldn't it be nice if Dr. Fauci were to use this slide before his talks? Next slide. So I'm here because, along with Dr. Bowden and Dr. Paul Merrick, I'm a plaintiff in a lawsuit against the FDA over the use of ivermectin for COVID. And this lawsuit was first filed in Southern Texas District Court in May of 2022. And initially, the trial court accepted the FDA's argument to dismiss it on the grounds of sovereign immunity, meaning that the FDA can do whatever it wants, and they're sovereign. So we appealed that to District Court, 5th District Court in New Orleans, and they reversed that ruling and said the FDA does not have sovereign authority in this matter, and they cannot do whatever they want, and specifically they cannot act as a physician. And so one of the quotes is, even tweet-sized doses of personalized medical advice are beyond FDA's statutory authority. So the FDA could have appealed that to the Supreme Court, but they chose not to, so it was remanded back to the District Court in Southern Texas for further arguments about standing, and that is ongoing right now. So how did I become a plaintiff in this lawsuit? Well, next slide, please. First of all, somebody that used to be very close to me in June of 2020 became very sick with classic COVID symptoms. And when I say very sick, she had oxygen saturation of 82%, which is life-threatening, just 48 hours after the onset of the illness, which is quite unusual. And she told me that she felt like there was an alien in her body and that she was going to die. I mean, she was convinced she was going to die, but she refused to go to the hospital or the ER. And 24 hours after the onset, I got her started on what was then known as the Zelenko protocol, which was hydroxychloroquine, azithromycin, and zinc. And she didn't seem to respond. In 24 hours, she hadn't changed much. And had her on CPAP at home, which she was dependent on. And at that time, June of 2020, this is very early, and I was still practicing emergency medicine at the time, not doing COVID treatment full time. So we were just starting to hear some anecdotal reports of ivermectin, so I thought we should try that. But at that time, I couldn't find any dosing recommendations for it at all. So I thought we'd just give the dose that was used for parasites, which was a single dose of 12 milligrams. Now, if I was treating that same patient, I would do 30 milligrams a day for 2 days and then 15 milligrams a day until she got better. Some other doctors would do 45 milligrams a day for 5 days. So a single dose of 12 milligrams was a very small dose. And then I found out later that she didn't really trust this recommendation, so she didn't take the full 12 milligrams. She took 6 milligrams. And a few hours later, she suddenly started to feel like she wasn't going to die, so she took the other 6 milligrams. So with that single dose of 12 milligrams, she turned around completely, ultimately had a complete recovery. And so at that time, I thought, ivermectin is truly a miracle drug. I had never seen anything in my medical career where you could give a patient that was dying a few pills and they recover completely. And I'm not claiming that this is a typical case. It's certainly not. And we saw, more dramatic responses to ivermectin with the early variants, and I wouldn't use it as a single drug now. But this really got my attention. So then I retired. Next slide, please. I retired from emergency medicine in July of 2020, but in April of 21, I started doing telemedicine for COVID with myfreedoctor.com, as I told you before. And I've done 15,000 patient consultations to date. It was a bit daunting for me to start doing continuing patient care, which I hadn't done as an ER doctor, and certainly with some very sick patients. And in that first month, I did have a couple of patients that didn't respond very well to treatment, ended up going to the hospital, getting admitted, and dying in the hospital. They were very high-risk patients. One was 84, one was 62, but came to me late and already hypoxic and had previous cancer chemotherapy. And but I analyzed what I'd done with all my protocols, and we were trying a whole variety of drugs for COVID at that time, a lot of different drugs. And one thing I hadn't done in that first month, which I changed, was I hadn't been using an antibiotic on the theory that why are we using an antibiotic for a viral disease? But it seems like there's some real synergy between particularly ivermectin and doxycycline, or hydroxychloroquine and azithromycin. And since making those changes, I haven't had a single death, again, with 12 or 13,000 patients anyway that I've treated. And I was frequently getting feedback of, you saved my life, you saved my family member's life, or I can't believe how quickly I got better and how well I feel. So, and I got that feedback far more than I ever did in emergency medicine. Next slide, please. So then another case I had, so I'm licensed in Arizona and Washington. Early in the pandemic, until last May, we were able to treat for COVID in all 50 states under the PrEP Act. And so I had a patient from Iowa, a 57-year-old female who had rheumatoid arthritis and was on immunosuppressive drugs, so very high risk, and successfully treated her with a cocktail of drugs, including ivermectin. Ultimately, she wrote an affidavit in my support. She was very upset because she couldn't get her ivermectin filled at a Walgreens. So she did ultimately get it filled and took it and recovered. But she filed, unbeknownst to me, she filed a formal complaint with the Iowa Board of Pharmacy against Walgreens for not filling her prescription. So the Iowa Board of Pharmacy said, well, there's no problem. Here, we'll just turn it over to the medical board to investigate the doctor. So the medical board then did a 60-page workup on me that included the FDA's "You're not a horse, you're not a cow" PR campaign. And they not only started an investigation of me, but they copied it to Arizona and Washington. So I got 3 medical licensing board investigations because my patient who did well complained about not getting her prescription filled. Next slide, please. So I've had 2 years of multiple medical board investigations. They have not identified a single patient complaint against me or a single adverse event. Next slide, please. So this is the Washington Medical Commission's current determination. This is basically a letter they sent me that's agreed upon order. If I sign it, I can keep my license. We're still negotiating with them. I have not signed it, would not sign this. But it includes that I would not prescribe ivermectin or hydroxychloroquine for any non-FDA approved indication, which obviously means COVID. This is right after we had that Fifth Circuit Court decision saying the FDA can't give that kind of advice, but the medical board is taking it. This is against the Hippocratic Oath and against the practice of medicine. And then the second item, they are requiring that I give no vaccine exemptions of any kind for any vaccine under any circumstances. Again, this would be a violation of the Hippocratic Oath in my ability to treat patients the way I feel they should be treated. Obviously, it's not proper practice of medicine to do that. They also want fines, expensive time-wasting, continuing medical education, annual personal appearances, extra reporting requirements, and pay unspecified costs of the commission. So, next slide, please. The Arizona Medical Board is not quite so egregious. They've concluded their investigations of me. They want me, again, to do expensive, time-wasting, continuing medical education on ethics. They specifically want me to do a 2.5-day course with a $2,300 tuition to it for, BS, frankly. And then they issued a non-disciplinary advisory letter, which basically says, we don't have enough evidence to act against you, but if you continue doing what you're doing, we will, but it doesn't define what it is that if I were to continue it, they would take further action. However, in their investigations, they had two main concerns. One was they felt I was not keeping medical records properly. Well, this all had to do with the fact that My Free Doctor was using a company for its internet platform, a company called Medici in 2021, and then there was a falling out between those two companies, after which Medici would not allow us access to our records. So I could not produce those records for the commission, and we did tell them on more than one occasion that we would cooperate with any attempt to get those records. And interestingly, the Washington Medical Commission did get those records, but the Arizona Medical Commission did not and blamed me for it. It'd be like the hospital owning your records, the hospital going out of business, and you couldn't get the records anymore, and then taking action against the doctor for that. The other issue that they had, and I think this is really worth attention in the state legislative arena, is an idea which seems to be being promulgated across the country in various states, that you have not established a physician-patient relationship if you didn't do a physical exam. And this is at a time when doctors in their office were telling patients not to come in to see them in person. But they took the position that I had not properly established a physician-patient relationship. Even though we had, a detailed history questionnaire, I'm following the patients closely. There's texting back and forth. And I'm following patients much more closely than many doctors do in the normal practice of medicine. So, and I'm not convinced that I actually was in violation of the letter of the law and the statutes, and there are exceptions to this even in Arizona law, but this is what the position the Arizona Medical Board took. And I think it's based on advice of the Federation of State Medical Boards that they're pushing this around the country. But I don't know if it being applied to anybody that isn't doing telemedicine for COVID.
That doesn't make any sense.
Next slide, please. So I don't want you to try and read this slide, but I just wanted to give you another story about the effectiveness of ivermectin. This is the greatest achievement and triumph of public health in the history of the world, in my opinion, that you've never heard about, because it was completely censored and suppressed at the time, as well as since then. They've pretty much wiped everything off the internet about this. Uttar Pradesh is the most populous state of India. It's in northeast India. It's about 240 million people. So it's 2/3 the population of the United States. And in 2021, the vaccines were first coming out, their COVID gene therapies were first coming out, but there was very little uptake in Uttar Pradesh. On the other hand, they'd had quite a bit of experience with ivermectin anecdotally, and different people were using that. Next slide, please. So you see on these slides that this is an article from Wikipedia about the public health response to COVID in Uttar Pradesh. So it's specifically about the public health response to COVID in that state. They have a detailed timeline that started in March of 2020. Next slide, please. And ends in April of 2021, and then nothing. Next slide, please. Oh, we need to update this article. We don't have any information. We can't get any information. What? You can't get any information about what happened after April of 2021? Well, what did happen? Next slide, please. So this is a picture of an early treatment kit that they widely distributed. They started in April of 2021 with 140,000 community outreach workers. This kit has a thermometer, an oximeter, Tylenol, vitamins including zinc, vitamin D, ivermectin, doxycycline, masks, gloves, hand sanitizer, alcohol wipes, all of that for $2.90. 6 months later, next slide please, more than half the districts of Uttar Pradesh were declared COVID virus free. Gone. They had less than 1 death per day in 240 million people compared to 2,000 or more in the United States. They had fewer than 20 or about 20 cases per day in 240 million people compared to about 150,000 at that time in the United States. I was going to put this on a bar graph, but the Uttar Pradesh would be a line so faint you couldn't see it compared to the bar of the United States. Next slide, please.
Dr. Apter, may I ask you a question? When we're talking about Uttar Pradesh, we're talking about a highly dense, I mean, they're in very close contact.
Right.
So we're talking about a highly communicable disease.
Right.
And we're talking about a population that has a density that's higher probably than any of our very populated cities, I would assume, with the exception
Absolutely.
of New York and LA, but
Yes. And they completely wiped out the virus with this program.
for $2.90
Without
a day.
vaccines. They had maybe a 5 or 10% COVID vaccine update, if you want to call it a vaccine.
Okay, thank you.
So let's look at what's happened in the United States. This was in February, according to the CDC, we'd had something like 1.2 million deaths from COVID. Now, a lot of people don't believe that number. But if you do believe that number, in my opinion, 90% of them would have lived if they'd gotten early treatment with multiple repurposed drugs and nutraceuticals along the lines of programs that Dr. McCullough has promoted. So that is in itself 1 million unnecessary deaths, if you believe those numbers. Next slide, please. And then we got the COVID gene therapy. So a very sophisticated analysis was recently published by Denise Rancourt based on a statistical analysis of COVID vaccine campaigns in the Southern Hemisphere, not in the United States, and looking at the death rates and the excess deaths. And I think it's the most sophisticated analysis that I've seen. And he came up with this number that there was 1 excess death for every 800 COVID shots. And if you believe that number, and I think it's a reasonable number, it's probably an underestimate because I think it's not probably picking up long-term adverse consequences like immune-related problems or cancer. He came up with 17 million deaths worldwide, and based on the number of shots given in the United States, that would be, again, getting close to 1 million deaths in the United States. Next slide, please. So this is another slide of excess mortality published by somebody called the second smartest guy in the world. But you see that vertical line is where the shots were started. This happened to be in ages 0 to 24, but you can see similar things for other age groups, and you see the excess mortality just climbing after the COVID vaccinations were instituted, and not before. We did not see this in 2020 when there was COVID, but there was no COVID gene therapy. Next slide, please. Cancer mortality, this is for ages 0 to 54, same thing. Next slide, please. This data is from Ed Dowd, who's done a lot of analysis of disability data. The syringe there indicates when the vaccine program was started, and you see labor force disability climbing after that. The drop at the end of the slide does not indicate a drop in disability cases. That's the amount of increase, and it's still increasing. It's still above 0 there. His estimate, at least at one time, was that we had 3.5 million more disability cases in the United States since the COVID vaccinations, which is about a 10% increase in our overall burden of disability. Next slide. And this is data from the UK with those are new disability claims, again showing the same thing. Next slide, please. And this is the same data presented differently, where the bars represent the excess disability cases. Again, starting just after the vaccination program. Next slide. I'm sure you can't read this. This is data from Jim Thorpe, who is an OBGYN who's done a lot of work in this area. And this is actually a published peer-reviewed paper where he looked at VAERS reports, the Vaccine Adverse Event Reporting System. And the CDC has a standard that anytime there's more than twice the level of adverse events reported compared to the flu vaccine, that it needs further investigation. Now, we don't know the flu vaccine is safe either because it's never been compared against a true placebo. But in any case, this is on a log scale left to right. So one or the same amount of reports is the very leftmost line, but the next line is 2, and everything to the right of that would exceed the CDC's criteria for requiring further investigation. You see the one that's farthest to the right is menstrual abnormalities, where it's like 300 times the rate of reporting for flu vaccine of menstrual abnormalities. But most of these are in the range of 10 times. Miscarriage, fetal malformations, fetal cardiac disorders, fetal growth restriction, abnormal fetal testing, low amniotic fluid, preeclampsia, premature rupture of membranes, premature delivery, and fetal stillbirth. Fetal stillbirth is about 9 times the rate reported with the flu vaccine. Next slide, please. That's the reference of Dr. Thorpe's work. Next slide, please. So we seem to have had a worldwide coordinated agenda. First, it's the creation of deadly pathogens in the lab, and then suppression of effective, inexpensive treatments, then totalitarian measures such as lockdowns and business closures and school closures, and then promulgation of an experimental, untested, and ultimately dangerous therapeutic regimen, meaning the COVID so-called vaccines, and then an unbelievable campaign of censorship and propaganda that I never would have believed could happen in this country. Next slide. So we really have to ask, what is the real agenda? If you ask the World Economic Forum, the CDC, and the NIH what is top on their agenda, they seem to be talking about reestablishing trust. But their idea of reestablishing trust is spending millions of dollars on psychological studies of how to persuade people and hundreds of millions of dollars on PR campaigns. But they seem to have completely overlooked what you would think would be the first thing in reestablishing trust, which would be to act trustworthy. That doesn't seem to be a part of it. So is the agenda profit? Certainly Big Pharma has a profit motive. They're expected to do that. Is the agenda depopulation? Some people think so. Is the agenda totalitarian control? I don't think we really know what's at the bottom of this. I certainly don't. But we have to ask who benefits from the agenda. Next slide. So in any case, you've seen all the unnecessary deaths from COVID and COVID maltreatment, the unnecessary deaths from the vaccine, as well as effects on disability and fertility. The agenda needs to be stopped, and there needs to be accountability. Last slide. Thank you. That's a picture there from Sedona of, it's an entirely natural rock formation, 200 or 300 feet high, called the Dream Speaker, way back in Boynton Canyon, that not too many people get a chance to see. Thank you.
That's beautiful. Thank you, Dr. Apter. Thank you very much. I just have a few questions, and of course, at this point, anyone has any questions. I think one of the most important things to have up here on the dais is a dialogue and a conversation about what we're talking about and what we can do. So, I asked Dr. McCullough, all medications go through a double-blind placebo study. And I asked him, are there any vaccines that go through a double-blind placebo study? And he says that there is not.
Well, let me clarify that. Historically, the childhood vaccines were felt to be so essential that children weren't subjected to a placebo. So as the measles, mumps, rubella, Haemophilus influenza B, et cetera, were tested, they were simply tested against a predicate version of a product. Now, recently, we have had placebo-controlled, double-blind, randomized trials. We had them in COVID-19, And as the data have come out, that when all the measures are in, there were more deaths with Pfizer than placebo. This has now been published in a paper by Michaels and colleagues. Pfizer had concealed some of the deaths that occurred in their group at the time the FDA reviewed it. So we do have a placebo-controlled trial. We do have placebo-controlled trials now on maternal vaccination with the RSV vaccine in the third trimester of pregnancy to theoretically protect the baby. And in today's New England Journal of Medicine, it was disclosed that GlaxoSmithKline's product, its maternal vaccine, caused more premature deliveries and premature babies than placebo. And GlaxoSmithKline stopped their use of that vaccine in clinical trials. So when we do have placebo-controlled randomized trials, they do tell us the truth. And we should demand randomized trials. So at this point in time with the COVID-19 vaccine, the prospective double-blind randomized placebo-controlled trials showed there was a reduction in new cases of COVID, but it was overstated because the proper methods weren't used. It was called intent to treat principles. And there was no reduction in hospitalization and death. In fact, death was slightly worse with the COVID-19 vaccine. So any FDA official, our president, senators, congressmen, healthcare administrators who say that the vaccines reduce hospitalization and death or make the syndrome less severe are making false claims because the randomized trials don't show that.
So then every vaccine that has gone to market did not have the double-blind placebo randomized trials prior to it actually going out into the population. And I think that this is a point where I would normally, I would look over at Mr. Siri and say, and so then all of these manufacturers have zero liability for these vaccines, for injury from these vaccines.
In 1986, under President Reagan, HHS and the Congress wrote the vaccine injury compensation legislation. And in that legislation, it said that vaccines all of them have unavoidable harms. And the reason why they're unavoidable is once the injection occurs, you can't get it out of the body. So it's unavoidable when a side effect starts to happen. You can't stop it. And because of that fact, vaccine companies were saying, listen, we're going to pull our products off the market because we're getting sued over and over again. And under President Reagan, Congress, and HHS, they told the vaccine companies by law that they are immune from any lawsuits. So if anybody has a problem, it's basically you cannot go after the company. That has been carried forward. With the COVID-19 vaccines, it's not only the Vaccine Injury Compensation Act that could be used as a liability shield, but it's also the PrEP Act. The PrEP Act was written in 2005 between HHS and Congress, and it said in a pandemic, anything we do in a pandemic that's considered countermeasures, including vaccines, use of remdesivir and the other drugs, that they are immune from any liability.
Every time I hear that, I'm disgusted. I don't know how anyone else feels about that, but that bothers me. It bothers me that we're saying you have to do this, and if you are harmed, there's nothing you can do about it. There's no other product out there in the world that has that kind of protection. Dr. Bowden, would you like to?
I would be honored. Do you have my slides? No?
Did we not have your presentation? You sent slides?
Yeah. Can I send them right now? Maybe somebody else could.
Absolutely. We can definitely do that. So one of the things that I found interesting about your presentation, Dr. Apter, is When we first started this committee, I asked research and I asked HHS and I said, can you get me the data on the deaths in Arizona? Can you get me the data on how many people suffered from COVID-19? They tested positive and they died from COVID-19. And I found it interesting that we're having a hard time tracking that. And I was told that there's a number of reasons. The ICD-10 codes were changed, what they were told to utilize to for diagnosis and billing purposes changed throughout the pandemic. And so that is making it hard to track. Well, Mr. Dowd, and correct me if I'm wrong, but isn't he utilizing insurance actuaries to come up with a lot of this data?
Yes.
And isn't he the one that's been putting out a lot of information on the fact that these deaths were miscategorized?
Yes, he's written a lot about that.
So can we surmise on why would it benefit the system with, I mean, ICD-10 codes are what we use for diagnosis as well as what we use for billing. And so a doctor would diagnose someone with COVID-19 and that's what goes into the chart. What is it that they were manipulating that is creating this division in being able to gather that data, but yet on the backside, we're able to get it with insurance actuary data? Can you explain that a little bit?
Well, I think there's a lot of ways that they can manipulate the data. For one thing, when they looked at vaccine adverse events and a lot of the reporting, it was assumed that the vaccine didn't take effect for a couple of weeks. So any adverse event that occurred in the first 2 weeks after a COVID injection was labeled as non-vaccinated. When in fact we saw people that were more likely to get COVID at that time, and of course were dying during that time, and those were attributed to being unvaccinated because it was within 2 weeks. So it was completely false data. In a lot of cases, we don't have reliable data for people who have suffered adverse events or died. We don't have reliable data about whether they were or were not vaccinated. Then there's ICD-10 codes. My understanding is there is not an ICD-10 code for an adverse event from a COVID vaccination. So if somebody dies of that and a doctor has to code it for a death certificate and he doesn't, that's not one of the codes, that might end up being called long COVID or it might be called COVID. So there's that. Then anybody that had a positive test in the hospital was diagnosed as having COVID by these rules when they might have gone in for a broken arm. And it has nothing to do with it. And then the PCR tests were being used and it was being way overdiagnosed. So people that did not have COVID were being said to have COVID. So there's a lot of ways the data has been corrupted and manipulated. And my experience in looking at the literature over the last couple of years is, the government has done everything they can to obscure the data. A lot of the best data comes from other countries.
That scares me. Does that mean also then if we have, with the remdesivir protocols that they utilize, does that mean that we would not have actual true data on whether or not, it would be hepatorenal failure, I'm assuming. It would be coded as something along those lines, but it would not actually be linked to giving this medication, correct?
Well, there are certainly manuscripts published from around the world regarding in-hospital outcomes and the use of remdesivir. The one way to think about a hospitalization is that someone dying of COVID-19 in the hospital is a failure. It's a failure. The hospital was supposed to save lives. There shouldn't have been a single death in the hospital. That should have been the demand from Americans. The observation that there were almost no deaths of people at home with COVID is startling. You'd think that if this indeed was truly an illness with a natural history and a fatal outcome, there would be people dead at home. Mm-hmm. You would just think that's the case. One cannot find manuscripts or reports of that. In the United States, it's virtually all the deaths occurred in the hospital. So the question on the table is, what occurred at in the hospital that failed to save lives? And so we're going to go through this today, but the codification of data from the hospitals And the fact that the hospitals are not meeting and having best practices meetings, they're not having comparative outcomes. You can't go on a website here in Arizona and find the hospital that has the lowest mortality rate, the lowest ventilator rate. You can do that for heart bypass surgery, cancer outcomes, but you can't do it for COVID. That should be bothersome and worrisome to each and every citizen of this state. And I would say that we should demand transparency. Our CDC should immediately merge the vaccine administration data with the National Death Index. Our CDC holds both sources of data. There have been requests in the United States to do this. There's been requests across all of Europe to do this, where they have a very, very accurate data, and not a single government has merged the vaccine administration data with the national mortality data in the world.
One more point on the renal failure with remdesivir in the ICU. So in the ICU, it's quite complicated. Renal failure is something we see all the time, and it can be due to sepsis with hypotension, septic shock it's called. There's many reasons you can get hypotension, and then the kidneys are the sacrificial organ, the first one to go down. Also, almost every patient in the ICU got a CT scan with contrast. Contrast-induced nephropathy is called, where you can potentially damage a kidney. However, every patient in the ICU at one point was on remdesivir, and it took me a while, unfortunately longer than I would have liked, but I saw remdesivir was absolutely ineffective. The study showed that, but we had the protocol, and every time I would stop it, one of my colleagues would restart it on the next shift. So it was like this merry-go-round of stopping, starting. Really hard to tell. I would have loved to have a cohort of my patients who I stopped remdesivir on completely versus another group to see exactly what the incidence of renal failure was. But I'd say, from my experience, at least 30% of patients' renal failure, I would say, was induced by remdesivir, and possibly higher.
I would like to say of all the patients I treated, and of course these are outpatients, but I only had a couple that ended up going to the hospital not doing well. I'm not aware of any of the patients I treated developing renal failure. None.
I had research pull up. We have in Title 36, Article 36, 3601, we have the actual definitions for telehealth. So there's a whole delivery of healthcare through telehealth, the requirements and the exceptions. We have the state jurisdiction and the scope, the use of telehealth, healthcare providers, the determination of the medium, interstate. It's very prescribed. So I'd be very interested to look into exactly where you were not following that with what you were doing as we move forward with this. It's very interesting to me.
Yeah, they said I had not established a physician-patient relationship because I had not done a physical exam.
Yeah, then I'm going to that's something I definitely want to look into. Dr. Bowden, it looks like your presentation is ready to go.
Thank you so much. So I'm Talley Bowden. I'm a ear, nose, and throat doctor in Houston, Texas. And yes, I'm not from Arizona. There are not a lot of doctors that are willing to go public. I was sort of thrust into it. And I think when you hear my story, you'll understand why we've got 2 doctors here from Texas and not a full panel from Arizona. Next slide, please.
You're a brave one.
So over the last 4 years, I've had to reevaluate so many truths that were ingrained into me during my training. Not only did I have to pivot, but I had to pivot in a very public fashion and fiercely defend my reasons for pivoting. Prior to the pandemic, these are some of the truths that I held, and they were acquired during 4 years of medical school, 5 years of residency, and 19 years of practice. First, viruses can't be treated. During my residency, the prevailing theme was, overuse of antibiotics will lead to antibiotic resistance. So we were trained to wait. So anybody that came in with a respiratory tract infection was presumed to have a viral infection until proven otherwise, and we were cautious about over-treating with antibiotics. So that is every doctor is trained to wait, and that was a fatal mistake during the pandemic. Secondly, all vaccines are safe and effective. This was a commandment during my training. It was not up for debate. The only thing I actually remember was celebrating the protection, the liability protection for the manufacturers of the vaccine, so they wouldn't suffer undue hardship from all the lawsuits that would have befallen them had they did not have those protections in place. Number 3, the FDA and the CDC are trustworthy and have little control over my practice of medicine. Honestly, I never thought about these entities prior to the pandemic. The FDA, they develop drugs, they regulate drugs. That's not what I do, just really not something I'll ever have to worry about. The CDC, they manage outbreaks, right? And that's in third world countries. Our health system's so advanced, we'll never have to worry about that. I just really never even thought about these entities. And then number 4, politics has no role in healthcare.
Amen.
Well, it does, it shouldn't, but as we have found, it certainly does. So next slide, please. So this picture was taken 8 months before the start of the pandemic, and at the time I was a full-time mother. So I had 4 boys in 5 years, and I took a lot of time off just to be a full-time mother. And I, for some reason, decided to go back to work 6 months before the pandemic started. So
Lucky you.
And so, I spent basically 5 straight years in an obstetrician's office, and it really taught me what it's like to be a patient. It changed the way I practice medicine, and it made me more empathetic. They say that good doctors treat diseases, great doctors treat patients, and I did not understand this difference until I had 4 children. So when I went back to medicine, I decided I was going to do things differently, and I started a cash-only ENT practice. But I call it third-party free. So I have no contracts with the government. I have no contracts with hospitals. I have no contracts with insurance companies. And the only people I work for are my patients. And this model proved to be invaluable during the pandemic. So next slide, please. So it was literally, I think, almost 4 years exactly to this day, and I stumbled into COVID. I had patients coming to me wanting to get tested who were sick. They were all coming back from their ski trips on spring break. And so LabCorp was the first lab to offer the test. And they became completely inundated. It was taking 2 weeks to get results back. The government was rationing who could get tested. So I found a lab. I was already working with them for other things, and they came up with a PCR saliva test for COVID. And my clinic is in a strip center, so it's perfectly situated for this kind of setup. Patients would be given a cup. They would spit in the cup in their car. They would place the cup in the basket, and then I would text everybody the next night with their results. It was a lot of work. I had 1 employee at the time. We were open 7 days a week. The picture on the right is getting ready for the day of testing, all the cups lined up with labels. And because we were one of the few places in town where you could get results back quickly, my little practice exploded. Initially, I told people, go see your primary care doctor, but we know how that went, right? The primary care doctors shut their doors, and they told patients, just wait till you can't breathe and then go to the hospital. And this did not sit well with me. So I didn't know about ivermectin early on. I just used common sense. I did breathing treatments. I did portable breathing treatments in people's cars. I did antibiotics and steroids. And then when monoclonal antibodies came out, I used those, and those worked very well. And I never rationed them. I didn't base it on the race or age, et cetera. Okay, next slide, please. So I'm going along and doing my thing, and then the shots come out that winter, and then in the spring, the FDA publishes this on their website, why you should not use ivermectin to treat or prevent COVID-19. The title is a clear directive. It's a clear mission statement of the FDA stating that you should not take this medication, and that is not the role of the FDA. The FDA tells you if a drug is approved for human use, but that is it. They are not allowed to tell doctors how they should treat a certain disease, and they're not allowed to tell patients how they should be treated. This was a clear violation of their role. And then next slide, please. Pay close attention to the dates. This is very orchestrated. So 10 days after they put this on their website, Biden is discouraged because the uptake of the shots is low. Only 20% have received one dose. He unleashes a $1.5 billion PR campaign to convince every American to get vaccinated. This is 10 days after the FDA issues a directive on their website. Next slide, please. And then 2 weeks later, the Houston Methodists, and that's where I had privileges, they become the first hospital in the country to issue the mandates, and this was 3 months before the government. I think Houston Methodist was chosen. I believe that they knew if they could get away with it in the seemingly red state of Texas, they could get away with it anywhere. I had privileges there, but very loosely. I'd actually never stepped foot in that hospital. I'm ENT, I do outpatient. I just had it as a backup. And I was actually collaborating with them. I was sharing my data, and we were trying to get it published. So we had a seemingly good relationship. But when they came out with this mandate, I had all these patients coming to me very distraught, trying to decide, okay, do I take this experimental shot with no long-term safety data just in order to keep my job? So, and at this point, you can see 50% of Americans have received one dose. Okay, next slide, please. And just to give you a sense of where we are in the pandemic, we're on our third surge. So this is the summer of 2021, the fall of 2021. It's after the shots have come out and that winter. Next slide, please. So here comes the nuclear bomb. COVID cases are surging. The government's frustrated because not everybody has gotten the shots. And so the FDA issues this infamous tweet, and I'm sure all of you have seen it. There's no caption needed. It's the attractive healthcare worker nuzzling the horse, right? No captions needed, but the clear message is that ivermectin is for horses, not humans. Not surprisingly, 2 days later, Pfizer gets full FDA approval, an asterisk, because the shot that was approved is not the shot that was given. The other asterisk is because you cannot mandate a product if it is under EUA status. The next day, a flurry of mandates from big companies occurs across the country, and then actually 2 days later, the Pentagon issues a mandate for the military. Next slide, please.
And 2 months later, I was fired.
The tweet went viral, global, and the FDA celebrated. I won't read all that, but just, they were very, it was very intentional, and they were very happy about how viral it went. Next slide, please. The media loved it. They parroted it. There's so many examples. I chose this one. I thought it was probably the most egregious. Rolling Stone printing this false story claiming that the gunshot wound victims can't get access to care because there's so many ivermectin overdoses in the emergency room. A total lie. And that photo is like, it's from a different area, it's from a different season. It's just the entire thing from top to bottom was a lie. Next slide, please. 6 days later, Biden announces the mandate for that everybody with 100 or more employees, every employee must get the shots. Next slide, please. And then Houston Methodist, the first hospital in the country to mandate the shots, a day later, issues their own directive on the website of why you should not take ivermectin. Next slide, please. Back to monoclonal antibodies. So I was still using monoclonal antibodies. They worked very well. People would turn it around the next day. Initially, I could get as many doses as I wanted. I could just send an email or an order to the company, and the next day I'd get unlimited supply. So on September 13th, and this is 4 days after the mandates, the government takes over distribution of monoclonal antibodies, and you can see my email. I'm like, where is my shipment? I ordered 600 vials, and the MIA, I'm pretty sure I never got that shipment. Next slide, please. And then this story changed things for me in a dramatic way. This is Sheriff Jason Jones, surrounded by his 6 children, and he was hospitalized in Dallas. He had tried to get ivermectin before becoming sick, and he couldn't get it. He was on a ventilator for over a month. The hospital was talking hospice, and his wife decided to sue the hospital to try to get ivermectin, and she found me to be the expert witness. Next slide, please. You can see he was in horrible shape, and the hospital was just adamant that he could not get this medication, even though they were saying, you know, we're about to send him to hospice. The photo on the right is a picture of his feeding tube, but you can't actually see it because they have wrapped it so tightly with a towel because they're so worried that somebody might sneak ivermectin into him. So I got involved in this case, and I testified. And as part of the lawsuit, they needed a doctor who would submit the prescription for ivermectin. They'd done hundreds of these cases. This is the way they did it. The judge granted me temporary emergency privileges. The hospital did everything they could to block that. They made me go through the whole application process, which is incredibly arduous. You have to get, you know, letters of recommendation. You have to get confirmation from your residency program. You got to dig up test scores from 20 years ago. I mean, it's a huge pain, and it was actually not warranted. The CMS had actually waived all that during the pandemic, but the hospital ignored that. So anyway, they decide that I'm not quite worthy of privileges, even though I had a very clean record. I had no malpractice, no dings on my record, but they said that no, I wasn't worthy of privileges. And next slide, please. I heard this on the same day. Two other things happened to me. I had an operating room or surgery center tell me that I could no longer operate there if I did not get the shot. And then I had a patient come to me very distraught. She had bladder cancer, and her doctor at Methodist Hospital told her that she would have to find a new doctor because she was not vaccinated. So I sent this email out to my patients and basically saying that I was going to prioritize seeing the unvaccinated and not take new patients with routine ENT problems that were vaccinated. Well, I never upheld this, but it did create quite a stir. Next slide, please. The next day, I went on Twitter, and I tweeted the same message 25 times. I said, vaccine mandates are wrong, and then in response to that email, I got lots of feedback, good and bad, but I published screenshots from that feedback. So I tweeted this 25 times. At the time, I didn't have much of a following. You can see I had 21 likes. And okay, next slide, please. 5 days later, I get this text message, which, I mean, it turns my stomach still reading it. It's from a reporter at the Houston Chronicle asking me to verify, is it true that your privileges have been suspended at Houston Methodist Hospital? And you can see I was blindsided. I'm like, no, news to me. I have no idea what you're talking about. But Methodist Hospital, after seeing my comments on social media, decided to tell a reporter that they were suspending my privileges. Next slide, please. So then I go to Twitter, and they're tweeting about it. They put out a thread of tweets basically saying that I was spreading dangerous misinformation, harmful to the community. Next slide, please. And then the media picked up on it. It went global. So I was quite unprepared. I basically spent the weekend soaking it all in. And then on Monday, I decided I'm not going to take this sitting down. I hired a lawyer. I held a press conference, and I resigned from the hospital. Next slide, please. I kept on treating patients, and I thought things were, I thought my troubles were behind me for the most part. And then the medical board came after me. But the timing is no coincidence. So December 13th, the FDA sent a letter to the Federation of State Medical Boards, which is a private institution, and it's very mysterious, but they have this control over the medical boards, or sway. But the FDA sent them a warning letter about ivermectin. And then the next day, Houston Methodist reports me to the National Practitioner Data Bank because I resigned while under investigation. And then about a week and a half later, I get complaints from the Texas Medical Board. Basically, Houston Methodist Hospital reported me, and the Texas Hughley Hospital with Mr. Jones. And just to finish what happened with Mr. Jones, the hospital appealed. He never got the ivermectin, but his wife did rub it on him daily, and he actually made it out of the hospital. But he had a rough recovery. He lost half of his body weight during his hospitalization, and he never made a full recovery, and unfortunately, he died about 11 months ago. Next slide, please.
God bless his family.
Just to give you a sense of what the FDA going after ivermectin, it had a huge impact on my practice, and it continues to have an impact. And this is a partial list of the pharmacies that we kept on hand as, okay, these places will fill the ivermectin, because CVS, Walgreens, H-E-B, Kroger, Walmart, Amazon, none of them would fill the ivermectin. So we had a running list of compounding pharmacies, which, we were able to get around it, but it's expensive. They don't take insurance. They're not open on weekends. I mean, it definitely caused problems. We'd have to find them, close to everybody's house all over Houston.
Great way to have more death.
Next slide, please. And I don't know if the video will play. Do you think it will? If I can. Okay. Well, I would challenge some of these pharmacists if there was time, because I wouldn't. If I sent it to CVS, it would get delayed. So I only did it in non-emergency situations, and then I recorded the calls. I don't know if you can do that in Arizona, but in Texas you can. You don't have to tell them. So this is, if this will play, this is an example of the typical pushback we got from pharmacists. And I reported about 20 pharmacists to the pharmacy board, and they all got just dismissed, because there is a law in Texas that a pharmacist can reject a prescription for ethical reasons. This is the spirit of this is the abortion pill, but they took it in the wrong. They misused that for ivermectin. But this conversation is very typical, and so basically I would try to report them for other reasons, but it's not playing.
Well, it needs access.
Oh, okay. Let me. I might be able to. I thought I sent access. I might be able to play it here.
I have a question while you're working on that. Is Texas a right to tri-state?
Yes, but only for experimental, and ivermectin is not considered experimental.
So they pigeonholed it in the same way they did here.
Yeah, is that what happened? Yeah.
Yeah.
Okay.
Yeah, and I find it interesting. I mean, I saw where you had EEOC up there. I mean, the Civil Rights Act of 1964 is something I quote often when it comes to any kind of medical treatments. I mean, as a nurse, that's what I stand for, right? I'm an advocate for my patients, and there are patients who do not believe in receiving blood products from others. So it's very important to make sure that the paperwork and the discussion, all of it is completed prior to going back to surgery in case something bad were to happen. And I would be the nurse that would stand for what the patient believes.
Right.
And if that patient believes that they do not want any blood products, no matter what happens, then that's what we stand for. And it was kind of interesting to me that is, if you didn't, you would be fired. And I would argue you could be sued. But when we came around on the other side of it, they were using but the EEOC says this is okay. Well, how is that okay when it, for one and not another? Well, it's because it's an emergency.
Right.
Just to put some additional context on ivermectin, which is one of many drugs we used to treat acute COVID-19. There were dozens and dozens of randomized trials, observational studies that showed, number one, it's extraordinarily safe. It's safer than Tylenol through a large range of doses. Mm-hmm. And that, number two, it appeared to have a very prompt effect in helping people get through the illness. And in 3 papers that were summarized by first author Gougliakos and colleagues, showed that even in patients with low oxygen levels, they could promptly rebound at home and not be hospitalized. So in 2020, a prospective study was published in one of the best pulmonary journals, Chest, by Dr. Rushter and colleagues. He testified in the U.S. Senate on December 8th, 2020. And with ivermectin given in the hospital, which was easy to give orally or down an NG tube, there was a 50% reduction in Americans who took ivermectin in these Florida hospitals. So in the absence of any concerns on safety, every single American admitted to the hospital should have been administered ivermectin because it gave a chance at survival, and there was nothing to suggest that it was unsafe. Yet hospital administrators and chief medical officers and those in the hospital fought tooth and nail to be sure patients didn't get ivermectin. And multiple court cases like the one Dr. Bowden described went to court, and there were court orders to administer ivermectin. And this occurred in Buffalo, New York, in Chicago, and elsewhere. And when patients were given ivermectin, even very late in the illness, many were revived and survived. So the ivermectin story in the hospital is a very important one for people to understand.
It doesn't make any sense to me that we would allow someone to die rather than try something that, oh my gosh, it might hurt them. Seriously? I mean, it doesn't make any, I'm baffled by that. But what's even more disgusting is that I actually have it documented that it is against hospital policy in a major system here in Maricopa County. To this day, it is against hospital policy to prescribe or administer ivermectin after everything we know. That should horrify everyone. Dr. Bowden, please. It looks like you're...
The videos.
They called us and they said they're going to pick... They called us and they said they're going to pick it up somewhere else.
No,
Yes.
well, so y'all will dispense it then?
Well, no, because it was written for something that is not approved by the FDA.
Oh, okay.
Yes.
Well, you know that there's a law in Texas that if there's a problem with the prescription, the pharmacist is supposed to reach out to the physician. And if you
We
don't,
did. We tried to do it.
I have checked every means of communication with my office, and we were open yesterday, and I didn't get any notification. And I will be reporting this to the board. Can I have your name, please?
Reporting what to the board?
The fact that I was not contacted. So what is your name?
My name is Sina, S-I-N-A.
What's your last
And
name?
I really don't like the tone of your voice. It's as if you're threatening me or something. I don't
What's your
really
last
give
name?
a damn about reporting that to the board. I believe that I did the right thing, so don't try to be nasty with me.
What's your last name?
My last name is M-A-H-B-O-U-B-I.
M-A what? M-A-H?
Okay,
No,
you
no,
don't
no.
need my last name.
I
You
do.
don't need my last name.
Sir, what is your
First
last
name is S-I-N-A, and that's it.
Anyway, that's that was fully restrained. I thought I was pretty nice actually, but okay, next slide. And nothing happened with that. So that I would try to find other means to incentivize them to comply, but even turning them in for not notifying me resulted in nothing. So,
So what you're saying is that you could turn them in for actually doing something that you feel is unethical and against their practice, and nothing happens. But Dr. Apter has been turned in, and he has 0 complaints, 0 fatalities, and they can actually threaten his license.
oh, exactly, yes.
Okay.
I would just add that the U.S. FDA on its website made this very clear in 2018. It's on their website. You still see it today. That doctors should use drugs off their original advertising label when, in their judgment, they are fulfilling an unmet need. The unmet need was patients dying of COVID-19. So we were fully within FDA regulatory guidance in all the broad use of the drugs that we deployed for COVID-19, all of them. And what you can see here is you can see the FDA jumping outside of regulatory bounds and impeding the community standard of care, pharmacists impeding the standard of care, and hospital administrators impeding the standard of care. They were infringing upon the fiduciary relationship between a doctor and a patient, a doctor who was trying to save a life and the patient who was trying to survive. Mm-hmm. Everyone here and everyone listening to this should be extremely disturbed by all of those in those roles who performed this, who actually worked to harm patients.
Just one point I'd like to make about the ICU. I would estimate 35% of the medications we use are off-label or repurposed.
Yeah.
And just the other night when I was working, I thought, let me just put a quick list. Ketamine is a general anesthetic. I gave that for someone who had acute pain. Gabapentin is an anticonvulsant. I had to use that for alcohol withdrawal. Phenobarbital, a drug that we use as an anti-epileptic or seizure drug. I gave that for alcohol withdrawal. Haldol is an antipsychotic. I gave that for someone with agitation. Clonidine is a drug for antihypertensive. I gave that for alcohol withdrawal. Methylene blue, methemoglobinuria, gave that for vasodilatory shock. Anyway, I could go on and on and on. I've never been questioned in my entire career until COVID about ivermectin and hydroxychloroquine and fluvoxamine. Never, ever.
Now, that's another drug that I'd like us to talk about today, too. Yes, for sure.
Yeah, so
Please
yeah,
continue.
well, I mean, we never thought about the FDA prior to the pandemic, didn't even really cross our minds, and now we're suing them. Myself and Robert Apter and Paul Merrick, as Dr. Apter told you about, initially filed it November 1st, which about a year after all my initial drama. Next slide, please. The case was dismissed on the grounds of sovereign immunity, basically saying you can't sue the government, but that was overturned in the Fifth Circuit Court of Appeals. This was in New Orleans, and I was very grateful that I was there to witness this. And I have two clips from that. I don't know if we have those videos, or is it another? That basically we had 3 judges on the panel, and the one who was leading the discussion, Judge Elrod, was just amazing. And I have 2 clips from that hearing where she really put their lawyer in their place. I think it's loading.
Once the FDA has become aware that courts around the country are relying on the FDA to keep hospitals from allowing doctors who have privileges there from prescribing these drugs, and also aware that major pharmacies are refusing to fill these prescriptions based upon the FDA statements. And so it becomes aware of that it is allegedly interfering with the doctor-patient. Does the FDA have an obligation to speak again to clarify things so that people are not relying upon the FDA statements in this doctor-patient relationship? That's one question.
No, Your Honor, those pharmacies and those hospitals are sophisticated, independent third parties who are not controlled by the FDA.
But the courts are saying the FDA is why we're not going to order the hospital to let the doctor give the prescription.
I'm not sure which court decisions.
There's 5 or 6 of them, and it sometimes cites other health groups as well as the FDA. It's not just the FDA, it's a whole, but the FDA is prominently featured, usually first in these opinions.
Yeah, so the their social media campaign had far-reaching impact, not just the public, but the courts, the hospitals, the insurance companies, the physician organizations, the hospitals. And I think she made that point. And that information's still on their website. Those tweets are still up. Okay, then this one more clip.
Not purport to require anyone to do anything or to prohibit anyone from doing.
What about when it said, no, stop it? Why isn't that a command? That seems to me, if you were in English class, they would say that was a command, stop it. That is different than we're providing helpful information.
Your Honor, the language that the FDA used in these tweets were merely quips, and I don't think that these quips change the substance of FDA statements. As plaintiffs can see,
Is that a command? Stop it?
the tweets about the horse ivermectin were intended to advise consumers that they should not use ivermectin intended for animals and that this could be unsafe.
I'm sorry, can you answer the question, please? Is that a command? Stop it.
It's good.
I like that, Jeff.
Yeah, and then I didn't include this clip, but the FDA's lawyer did admit that the FDA has no control over physicians prescribing or using off-label medications, and that came out during that hearing as well. So the Fifth Circuit ruled in our favor, and we were allowed to proceed with the case, basically. So it went back to the district court, and then, of course, the government appealed again based on standing, saying that we don't have standing, meaning that, this is all great, but it really didn't affect us. Well, the judge ruled in our favor for that, and so now we start discovery. So it's moving forward, which is great. Next slide, please. And then I'm just this is sort of off track, but it has particular significance to me because on November 10th, this past fall, Governor Abbott signed the COVID vaccine freedom bill, and this took a lot. This was a third special session, but it was literally 2 years to the day after Houston Methodist, the first hospital in the country to mandate the shots, went after me. So it was very providential. Mm-hmm. And next slide, please. So back to where we started, obviously my views have changed tremendously over the last 4 years. Viruses can be treated. I've now treated over 6,000 patients, and everybody that received early treatment is alive and well. We have obviously a lot to learn about vaccines. I looked at my patients 2 years after the rollout of the shots. 7% of my new patient appointments were for patients with chronic debilitating health conditions following the shots. And it's just like what everybody else is seeing. It is neuropathy, it's POTS, it's bizarre rashes, it's chronic fatigue. I don't get the heart attacks and strokes because I'm not in the emergency room, but for the people with these long-term problems, I'm seeing what everybody else is seeing. And unfortunately, they are very challenging to treat. I mean, most people slowly get better, but they are challenging patients, and their lives are very altered, and they're not getting any help other than the few physicians out there. I mean, they get gaslit, they get the $1 million workup, and then they put on, I had a patient who was put on a sleeping pill, anti-anxiety medicine, and an antidepressant, and told just, go away. And I see this all the time. Number 3, the FDA and the CDC are not what I thought they are, and this whole thing is very orchestrated. None of these things are coincidences, and the goal was, let's get these shots out no matter what. And unfortunately, politics is ingrained in our healthcare system right now, and we can't ignore it. And I have started becoming more vocal about the politics. I didn't initially because I thought it weakened my argument. I didn't want to seem like I was motivated by politics at all. But at this point, we have so many facts behind us that we really can't just ignore the politics anymore. And finally, there really are no coincidences. You look at that timeline, the suppression of early treatment, the persecution of doctors who spoke out, It was all very orchestrated. And then final slide, please. So back to the politics, I have started, and this came out very accidentally. I just stumbled across a post from a representative in Michigan, Brad Paquette, who was describing being hospitalized for myocarditis after the shots. And I asked him, would you be willing to publicly speak about this and say that the COVID shot should be pulled off the market? And he wholeheartedly responded yes. And that just gave me the courage to ask more politicians. And so this started in mid-November, and now we're up to about 258 politicians on our list, and they can either be running for office or in office. All they have to say is just publicly state that the COVID shot should be pulled off the market. We have added on the pledge not to take donations from Big Pharma, so these people are also saying that. But the minimum is just simply stating that the COVID shot should be pulled off the market. At this point, they are all risk. They are no benefit. Any other product would have been pulled off the market a long time ago. The majority of people in Congress are defying CDC recommendations because you know they have not taken 9 shots. They're not giving them to their kids. So why aren't they speaking up? We're trying to raise awareness by getting more and more politicians to speak up, do the brave and hard thing. And I started a nonprofit to support them because, you know, when they put themselves on this list, they're putting themselves on a big pharma blacklist. So many politicians rely on money from big pharma. Our goal is to raise money to help these politicians so they can be free and independent from big pharma. And if you want to learn more, there's our website, americansforhealthfreedom.org. If you want to volunteer, the best thing you can do is reach out to your representatives, contact 10 of them today, make them aware of it, because so many people are not even aware of this effort. We have a wide range. We have people in Congress. We have Marjorie Taylor Greene, we have Thomas Massey, we have Ron Johnson, we have the Surgeon General of Florida, but we also have precinct chairs, we have school board members, so it's a whole wide range. So even if it's, you know, something that you think it doesn't matter, anybody who is in office or running for office can join this list. Thank you.
Thank you, Dr. Bowden. Yeah, Dr. Latipo was trying to make it to this committee hearing, but unfortunately scheduling conflicts. So we had a conversation about the politics when we first spoke, and it was interesting that you used the Rolling Stone, because as soon as this committee was announced, and myself as the chairperson of this committee, Rolling Stone did a hit piece on me. I mean, it was instant, like they were waiting. I think everybody knows I am the nurse that refused the vaccine, and I got mad and ran for office, right? We needed healthcare voices at the legislature. So I have yet to sign this pledge, but I think that everybody out there knows that I am completely and totally in full agreement that the COVID-19 vaccine should never have been allowed, and it should be pulled from the market, especially with all the data. So the only reason I haven't signed it is because I wanted to be able to say to you that I would be honored to sign it, and to sign it, and to say that to you personally right here on the record in the Arizona State Senate. That is something that I truly believe, and getting to the heart of why this was done is extremely important to me. And I think that by pulling the politics in and making sure, and there is a lot of pressure. There's a lot of pressure not to. Are you sure you want to do that, Senator? Yes, I am absolutely positive. So thank you very much for that effort. I appreciate all you're doing with that.
Thank you. That means a lot.
Yeah, I wanted to put some context on what Dr. Bowden described as the suppression of early treatment. So not only was there the suppression of and discouragement of the use of hydroxychloroquine, ivermectin, another valuable drug called colchicine, pharmacists wouldn't fill that. There was an attack on vitamin D, simply over-the-counter vitamin D, in a very visible case with someone who produced a vitamin D supplement, Eric Naputi. There were 5 monoclonal antibodies, which were some of the most effective, high-cost, high-tech drugs we could possibly use. Each one of them was taken off the market within a few weeks or a few months of becoming available. there was an absolute attack on nasal sprays and gargles. Simple nasal sprays that actually did work. Iodine, colloidal silver, xylitol, peroxide, scope, Listerine. There was an attack on using them to prevent and treat COVID-19. We didn't have the first FDA emergency authorized oral drug to treat COVID-19 until December of 2021, and that was Paxlovid. So we had 2 full years of this pandemic where Americans, according to the FDA, the CDC, the NIH, the media, and hospital administrators, could not receive a single ounce of treatment at home. For 2 years of this 4-year pandemic, it was not authorized for anyone to have any treatment at home. That meant one could only get sicker to the point of desperation and become hospitalized. Think about that. 2 years out of 4 years, nothing for Americans to help get through the COVID-19 illness over and over again. And now the data with Paxlovid has really fully come out, and I want to put this citation in the record. Yang and colleagues from JAMA just a few weeks ago, the first prospective study analyzing what the CDC warned us about. The CDC said in May of 2022, it said, watch out, Paxlovid could actually prolong COVID, cause rebound. Now Yang has reported in this JAMA paper, 21% of patients who take Paxlovid, 30 days later, get COVID again. They actually get rebound. They get sick, and the entire time they have the virus and they can spread it to others. So Paxlovid is in many ways more of a hazard. It prolongs the illness and causes rebound. And yet that was the only thing that was fronted to Americans. As doctors, we were desperate to help our patients get through the illness. Early treatment was suppressed, and even the first government offering, it was a flop. Molnupiravir, the next one was not messaged well, in my view, didn't work very well. And so we are now at 4 years into this pandemic. We have no monoclonal antibodies on the market. The National Institutes of Health still does not have a multi-drug outpatient protocol. They haven't adopted any of the ones that the practicing groups have adopted, like the Association of American Physicians and Surgeons or the Frontline Critical Care Consortium, or ones that were published by myself or Dr. Zelenko or Dr. Corey and Merrick or Dr. Rialt in France. And now our government says, as of August of 2024, they are taking down the treatment website for COVID-19. The National Institutes of Health, February 29th, 2024, said this is the last protocol that we're going to produce, and get it now, because in August, our government is just taking it down. With the pandemic still 4 years, and there still are COVID cases.
I don't even know what to say to that. So they've never come out with a treatment. They've never actually said, okay, here is an early treatment protocol that you can do. They've never said anything talking about prevention of disease, which isn't that what this is all about? But then the website is just going to disappear. I don't even know what to say. I don't know if I even really have a question. I'm dumbfounded, Dr. McCullough.
That is our government agencies. Think about the hospitals that you go to. None of them had an outpatient treatment protocol or a clinic that you could go to and get acute treatment. To this day, they still don't have it. What happened with COVID-19 is the U.S. public health agencies essentially said, don't treat it, and wait till you go to the hospital. The hospitals and the healthcare system shut down, and the entire burden of care was thrust under urgent cares, private practices and doctors that would see patients, doctors on telemedicine services, and then when patients got really sick, they went to the hospital. And to make matters worse, when they got to the hospital, and many of you know this, the family members that were taking care of the patient for the last 3 weeks at home now could not see that person in the hospital. And so many, in fact, the majority of Americans who died in the hospital died alone. Yet the family members were just with them for 3 weeks, but when they went into the hospital for the final week or two, they died alone. So our hospital administrators have to be called in front of you as citizens, and they have to be held accountable for what happened. Why did they not have outpatient treatment clinics to help patients get through the illness? Why did they not broadly use all the outpatient drugs that we were finding success with in the hospital? All of them. They should have all been continued. There's a process called medication reconciliation, which says everything the patient's taking at home, they should take in the hospital, and then we add hospital drugs to them. Why were patients stripped of medication reconciliation? Why were patients and their families denied the right to actually be together during the illness? And why did hospital administrators deny shared decision-making? When a patient says, and a family member says, I want to try ivermectin, or I want hydroxychloroquine, or colchicine, or salumedrol. I want a chance to survive. Why were they denied that? The hospital administrators, the chief medical officers, and the attending physicians must be held accountable for what happened, because no deaths should have happened in the hospital. None. And if there was a death in the hospital, they should have shown us that they pulled out all of the stops. All the stops. Everything.
Right. Yeah. I remember being a nursing student and being in the emergency department, doing my critical care rotation in the emergency department, and I was at County Hospital. And I'll never forget, patient comes in, and he was coded, and they just were continuing to switch out people doing CPR, and they were giving all of the drugs. And I'll never forget the attending physician looking around the room and saying, anyone else got any other ideas that we might try? And it is a teaching facility, so I will give that. But that stuck with me, that we do everything we can. Why did we not do everything we can then? And even more frustrating to me, we are not in the middle of a pandemic. We cannot use the excuse that we didn't know. We can't use the excuse of we were overwhelmed. It was an emergency, when it just happened within the last 3 months. That is not an excuse. They've changed nothing. In fact, I would argue they've gone the other direction, because now they must have had med-exec meetings to come up with new policies to actually make it against hospital policy to give ivermectin for COVID-19.
And to make matters worse, this is not going away. Patients are now being denied treatments for vaccine injury syndromes. This is very important. So some of the same drugs we use to treat COVID are because the spike protein is causing damage to organs and tissues. We figured out basically how to try to medicinally handle the spike protein. Well, in long COVID and in vaccine injury syndromes, it's the same process. So there are some long COVID or vaccine injury syndromes where ivermectin has been found to be useful. The same for hydroxychloroquine, particularly the autoimmune syndromes, which we use hydroxychloroquine anyway. And now for the heart, the pericardium and the lining around the lungs, the pleura, a very valuable drug is colchicine. Colchicine is a drug that was tested in randomized trials, and I want to put this into the record. Colchicine, a recent paper by Dan Juna and colleagues, summarized results in nearly 200,000 patients who received colchicine for acute COVID. There was a 32% reduction in death. This is a simple drug we've used for gout for decades. Now we use it in the vaccine and post-COVID chest syndromes. I had a patient go to a Dallas pharmacy recently, and the pharmacist asked, what is it for? The patient said, well, I have a long COVID syndrome, and I've taken the vaccine. And then the pharmacist denied the colchicine to the patient. So this is going to continue to happen unless people stand up in their states and begin to really make some noise.
So at this point, is this where we start FOIAing records to try to find out? I mean, is this something, how do we how do we find out why they're doing it? I mean, in order for an employee in any kind of healthcare situation, it is my understanding there has to be a policy for them to be able to do that. So this is happening at the administrative level, right? I mean, we're talking about the hospital administrators and the CMOs. So when we look at the pharmacies, wouldn't it be the same? It's policy that they're saying that we will back you up if you refuse to fill a prescription if it's being used in any way, shape, or form around COVID.
We need to have a pharmacy administrator or a pharmacist come forward and tell us what's really happening. Because pharmacists either have it in their mind or they've been told by protocol or by standard operating procedure to deny patients treatments in the context of acute COVID and now long COVID and vaccine injury syndromes. The problem is persisting as we try to help people through these difficult times.
If I could add something about the pharmacist, because I saw this 2 days ago. I had a surgery patient that needed pain medicine, and the pharmacist would not dispense it without a diagnosis. So these pharmacists are getting more and more controlling, right? And I don't know what's behind it. The pharmacist said, well, this is just CVS policy. And that's the only information I could get. But I think we've got to rein in these pharmacists.
Yeah, that's what my question is with policy. Is that something that's FOIA-able?
Well, if there was a government, it's worth asking, but if there was a government communication to a pharmacist, what we found, and I hope everybody's aware of this, is that our government is deeply involved in all types of communications in the country. A very important case right now, Missouri versus Biden, has been renamed Murphy versus Biden, is ongoing. But that case is essentially about government agents, of which we've never had so many government employees as we have now, by the way. We have well over 450 government agencies loaded with government employees. But the government is operative in social media, mainstream media, certainly through regulatory agencies, to healthcare, likely pharmacies and pharmacy boards, medical boards, Federation of State Medical Boards. But it's not to the best interest of patients. It's not to the best interest for a patient to see a doctor, get a diagnosis and a treatment plan, and go to a pharmacist and be turned down for any drug. For any drug. If a pharmacist has a question regarding the dose or the selection of drug, they must call and actually get a hold of the doctor and then get clarification on the prescription. What I found happened to me over and over again is the same thing that happened to Dr. Bowden. There would be an attempt at a call, and if I was in an exam room or in the hospital, they couldn't get me right on the line, they said, well, we tried, and they happily denied the patient the therapy they needed.
I would like to say that before COVID, I never got a call from a pharmacist for a diagnosis code or a diagnosis for any prescription for anything. It wasn't done. And of course, because it's perfectly legal and appropriate, and the FDA will say it's legal and appropriate to prescribe medications off-label, there was no reason for them to do that. But now they do.
Yeah, that's why I'm asking, is it FOIA-able? Because it's got to be coming from a government agency that's giving them the ability to have this information. I mean, even if it is a tweet, there's got to be a way to get this information. I mean, we're discussing a lot of the CMS documentation because we want to know. So what still today is the benefit to give remdesivir? Why would you give it with everything that we know? The Dr. Martin's study, 53% of the Ebola victims died from the remdesivir.
Well,
it was actually more fatal than it was to have Ebola.
Well, listen, research on remdesivir continues to come in. I want to give some quotes. Remdesivir is the National Institutes of Health frontline premier drug to treat COVID. Yep. In the guidelines, it is the featured drug that our National Institutes of Health, our CDC, the Infectious Disease Society of America, fully supports the use of remdesivir. This is what we have. Pat Niak and colleagues, in 2023, 5 randomized trials, no improvement in mortality. Ryu and colleagues, 2023, 8 randomized trials, different search criteria, 11,945 patients, no improvement in mortality. Schmill and colleagues, a fact registry, this is a registry, 31% of the time remdesivir has to be discontinued because of liver toxicity. Munoz and colleagues, real-world data with remdesivir. Of all the patients put on remdesivir in this Spanish study, 17% mortality. 17% mortality. The contemporary mortality for COVID should be close to zero at this point in time. I can tell you the outpatient treatment's okay. Even the most severe heart attack I treat as a cardiologist, the inpatient mortality is 2%. Kang and colleagues, 2023, the rate of renal injury, kidney injury on remdesivir. People followed through the course and they ultimately die of COVID, 80%. 80%. The WHO Vigibase pharmacovigilance database had warnings from the very beginning for liver toxicity and renal toxicity. The World Health Organization in November of 2020 said, it put a big notice on their website, do not use remdesivir for the inpatient treatment of COVID-19. Do not use it. Does not improve mortality. They reviewed that again in May of 2022, the WHO Solidarity Group, and they concluded they were right to begin with. Remdesivir does not improve mortality. It does not. It has serious toxicities to it. Everyone should be asking, why do hospitals stock and use remdesivir today? Why? That question should be asked. Everyone who knows nurses and people in the hospital administration, anybody on hospital boards should be asking that question. Again, hospital administrators must be held accountable, and hospital pharmacists should be held accountable. Why are they frontlining a drug of which every single analysis shows it does not improve mortality?
And I'd say also there's a concern about doctors in their thinking these days. Even if you were to consider using it, the mechanism of action is to stop viral replication, which is done in 5 days. These people are not coming in within 5 days. So you're giving a drug that absolutely, the mechanism of action has no impact, and all it is toxic. Right. So any doctor worth their weight in gold, they will not be giving this drug. And I can't tell you how many times I've documented all of the downfalls, the pitfalls in the chart, and lo and behold, the next day it's back on again. It's just really amazing.
May I?
Yes, please.
All right, thank you, Senator. In all fairness, this is my first time in the committee, and I know this has been done previously, a lot of testimony. And thought in my head had to do with the patient and their insurers, the insurance side. Okay, I have a personal case with my own spouse as a heart patient, and basically was forced to take the vaccine, otherwise forgo the heart surgery. Okay, so how is that? Because we brought up pharmacies, we brought up the doctors, we brought up the hospitals that are involved in this politically and otherwise. How is the insurance industry culpable here? Are they treating patients? Because you got the private insurance, you also have the government insurance, Medicare, VA, et cetera, Obamacare. Can you speak to that?
Well, I will say in terms of prescriptions, their favorite trick is pre-authorization. So any medication they don't want to pay for, they put this pre-authorization label on it, which delays care. You have to take time as a physician to argue with the insurance company why this patient should get the medication. So that's what we're seeing now with ivermectin. So if I send it to CVS and Walgreens, instead of saying we won't fill it, they'll say, oh, well, the insurance company won't pay for it. So it's just another trick. In terms of inpatient, I mean, maybe you could comment on, oh, you're the VA, but that's a whole different story.
Let me read my disclaimer before I get too far into this. I was advised by the VA to make this statements before I say any more. My contributions to this forum are my personal thoughts and opinions. The views expressed are my own and do not, they said to put necessarily, but I can tell you absolutely do not represent the views of the Department of Veteran Affairs or the United States government. So what I was able to write for ivermectin for about a week at the VA until they put the kibosh on it. And then I would write prescriptions for outside pharmacies. And then they started reviewing my charts and said I couldn't do that. So it wasn't even, prior authorization is another story for me, but I couldn't even, it just wouldn't be approved and I couldn't get it done.
So the issue on insurance coverage for drugs, it was easily solved with the idea that so many of the useful drugs were generic and they were very affordable. So you'll tell patients, listen, don't put it on your insurance, just get the medications. But the interesting observation is the insurance companies, did pay out for COVID hospitalizations. They are now paying what will have to be an astronomical sum for all the vaccine injuries and disabilities. This is extraordinary. As a cardiologist, I can tell you I've never ordered so many MRIs for myocarditis. I've never seen so many patients taking blood thinners for blood clots. Large blood clots that don't go away. And the patients that continue to go in through very expensive diagnostic testing for complicated neurologic problems. And I can tell you the tens of thousands of dollars that are being spent right now. And I haven't heard a single word of concern from the insurance companies on the amount of money they're paying. Whether they've paid for Paxlovid, whether they've paid for COVID hospitalizations, or they're paying for vaccine injuries or disabilities right now. It is just an interesting observation. And the question is about vaccination prior to surgeries. Vaccination prior to surgeries is not something that is common practice because vaccines cause fever, they cause inflammation. The COVID vaccines, our FDA has told us, cause blood clots. When we do a surgery, surgeries create a risk for blood clots. That's the last thing we would want to do is to give a vaccine and then have a patient develop a postoperative blood clot. So you can see how these practices that patients were told at virtually every single entry point in healthcare that somehow COVID-19 vaccination was part of their patient care journey, you can see how incredibly distorted this was. There's been vignettes of patients coming in with COVID and actually being administered a COVID vaccine in the hospital while they're sick with COVID. So something got into the minds of doctors all over. I'm a cardiologist. Vaccines are very far from my practice. Cardiac surgeon is even more remote from their practice. That somehow it got into their minds that a patient would have to take a COVID vaccine for a bypass surgery. It's very unconventional. A patient who's had bypass surgery was actually probably more at risk for a pneumococcal infection afterwards than COVID. But these are the types of questions people should be asking. People should ask their doctors, are you still pushing these vaccines? And this is a good word. That's pushing. That's pushing a vaccine. Are you still pushing vaccines? And why? Have you yourself taken 9 shots? Remember, a healthy person right now is on 9 shots. Someone who's immunocompromised would be on 12 shots. One should ask themselves, for what vaccine would we ever take 9 shots for? Or 12? This should start to make people feel very uncomfortable that something has gone very, very wrong.
Well, that's fine. That's fine. Doesn't satisfy the situation, but that's a fine answer. Thank you.
Somebody told me not too long ago that it was going to be the insurance companies that were actually going to uncover all this data, and that's why I find it very interesting with some of what's coming out that maybe that is where we'll actually get the information, because at some point the insurance companies are going to get hit pretty hard with this. I would think that they're going to kind of want to put a stop to it.
It's hard to know. Remember, the insurance companies in many ways are bookies, so they can always adjust by raising everyone's premiums. So Edward Dowd, is a former BlackRock executive, has published an entire manuscript on this. It's in a form, it's a monograph about increasing all-cause mortality since the rollout of the COVID-19 vaccines. Mm-hmm. So among working age Americans now, we are having marked excesses in mortality. People dying of working age. And so they have life insurance because they're employed, and the spouses are cashing in on the life insurance policies. And there are record claims. And we haven't heard anyone voice any concerns regarding this from this industry. And I would anticipate if we don't hear anything, there's simply going to be this blanket increase in premiums. That's how they compensate.
Just going to say one more thing about the vaccine. If your doctor tries to push it off on you, ask them what IgG4 means to them.
Yeah, good point.
And see if they can answer that question. IgG4 is something that causes immune tolerance, so it impairs your immune system, exhausts the immune system, rendering it ineffective. Also, IgG4 is something that comes in very small amounts in the body. It was once thought to be protective, but now we think it causes pathogenicity, meaning that the higher levels can cause autoimmune disease and even cancer, because IgG1 is the one that does surveillance for cancer, and IgG4 competes with it. So after your third dose, or between your second and third dose, the levels in your blood are about 0.04%. By the time you get your third shot, it's about 19 to 20%.
So what is that again for the audience and for everyone listening?
Oh, so it's an immunoglobulin. There's 4 subtypes for the IgG class. There's 1, 2, 3, and 4. And 4 is the one, it's based on how much you get of the vaccine. So either high dose or repeat vaccination. It keeps creeping up. And if we did our job and we gave the smallest amount possible, we may not have to worry about this. But the old adage of, more is better. They give higher doses of it, so that's what's causing the problem. There's no test to look at the trustworthy dose that you can give minimum.
There's a practical manuscript published in Circulation, one of our best cardiology journals, regarding what's happening with these antibodies after vaccination, this shifting to this ineffective IgG4. And the paper, the first author is Yonker and colleagues from Massachusetts General Hospital, Harvard. And they reported on boys in the hospital in Massachusetts General with vaccine myocarditis. Now, no American boy should be spending time in the hospital with vaccine myocarditis, yet they had a whole collection there at Harvard, and what they discovered was that the boys with myocarditis, they had circulating spike protein from the vaccine in the bloodstream, and these antibodies were ineffectively neutralizing it. Whereas comparison children who took the vaccine who didn't have myocarditis, they actually had enough antibodies, good antibodies, to neutralize the spike protein. So what we're understanding is that when the body begins to shift its library of antibodies, and we can't predict when this is going to happen, then people start to take on heart damage. That's the mechanism. It's basically unabated spike protein damage that's occurring in the heart, because the antibodies are no longer stopping the production of the spike protein. The spike protein is produced from Pfizer and Moderna now with each shot, at least for 6 months after the shot, maybe longer. This is a very long-term production of the spike protein in the body. Janssen, which is the old Johnson & Johnson vaccine, that's off the market. AstraZeneca, we never had it. There's a third vaccine on the market you never hear about. It's called Novavax. And it's a limited amount of the spike protein. It's 5 micrograms of the spike protein, a pure antigen. We know a lot less about that vaccine. And our FDA and CDC virtually never mentioned Novavax as an option. And what we discovered, and actually Senator Rand Paul discovered this, is that Pfizer and Moderna are using the same marketing firm called Weber Shandwick. And Weber Shandwick has an installed marketing unit in the CDC vaccine office in Atlanta. In fact, the CDC is paying Weber Shandwick to do marketing for Pfizer and Moderna under the auspices of the CDC and HHS. Senator Rand Paul called out publicly this widespread corruption and conflict of interest. So even among the vaccines, our agencies are favoring the messenger RNA vaccines very intentionally through marketing.
And where's our Federal Vaccine Advisory Council on this?
The many agencies right now are absent. The Federal Vaccine Advisory Council is one. The Office of Human Research Protections, OHRP, has been completely absent on this whole thing given the experimental use of the products. And so many, the American Civil Liberties Union was completely absent in people being stripped of their rights regarding all the issues that we've talked about. Now you see they jump right into it in the transgender crisis or some other civil liberties issue. But for COVID-19, none of the offices that were supposed to have oversight or offer anybody any patient protection, none of them fulfilled their obligations.
So I asked about the Federal Advisory Council. I found it interesting that I just read an article today that 9 new appointed members of the council, all previous employees of Pfizer. I mean, I talk about it all the time in government, how we have so much of the fox guarding the hen house. I mean, if that doesn't, I mean, that is, I don't even understand how this is happening. And God bless Senator Paul for pointing all of that out. So, you know, we talked last time, or actually, I think it was our very first hearing. I find information like this, you know, inserts for the vaccine. Papers there, and there's nothing printed on it. I find that very interesting, disheartening, disgusting, and lots of other words. But then it gets better. It just keeps, wait, there's more. It just keeps happening. The CDC redacts every single word of a 148-page study on a myocarditis after COVID vaccination. So I asked research to print the study for me. 148 pages. The entire thing is redacted. What good does a study do if there's nothing there? Then I want to know, wait, what might have been there that they needed to redact it? That's even scarier.
We're witnessing an active cover-up of a colossal consumer product safety debacle that is basically affecting the entire world. Mm-hmm. So in the United States, our CDC, National Institutes of Health, and the FDA are actively involved in a cover-up. And the same is occurring in the UK with the MHRA, Europe with European medicine agencies, and Australia with the Therapeutic Goods Administration. Something is going on that's very big. Each one of these companies that puts out a product has an obligation to produce 90 days of safety monitoring after their product comes out. It's a regulatory dossier. If somebody has a problem with the new product and they call the company like Pfizer, Pfizer has to report, write down what happened, and they have to collate that in a report and produce it and make it publicly available. When it came to 90 days with Pfizer, the first vaccine that came out, remember Pfizer was approved December 10th, 2020. Pfizer didn't produce a report. And then people started asking, well, what's happening with your vaccine? And Pfizer would not disclose what happened. And then it went to court. And the lawyer for the FDA stepped in and said they don't want to release Pfizer's dossier for 55 years. Mm-hmm. 55 years. And the plaintiff pushed. And finally, slowly, the Pfizer dossier came out. Pfizer recorded 1,223 deaths with their product within 90 days of release. People were calling Pfizer in desperation, watching their family members die after taking the vaccine. Pfizer recorded over 1,200 new adverse events, new problems that Dr. Bowden has talked to you about that we are grappling with the entire time. But the point is, our FDA worked to cover this up. The FDA should be regulating this company. FDA should have been having at least monthly meetings and fully disclosing what was going on with these novel vaccines, which are a genetic transfer technology platform. It's the first time human beings had ever been injected with foreign genetic material in world history. Now they were getting it full on. 2/3 of the world's population took these. In the United States, the best estimates are about 75% of Americans took a vaccine, of which 94% of the vaccine choice was a messenger RNA vaccine, Pfizer or Moderna. Another 5% probably was Janssen, an adenoviral vaccine, and probably less than 1% Novavax, the antigen-based vaccine. We're talking a lot of Americans have foreign genetic material now in their body. I recently testified in Congress on January 12th, 2024, and I reminded Congress that the FDA regulatory window of concern for a novel genetic product is 5 years at the minimum from the last shot and as long as 15 years. People keep asking me, when is the risk of blood clots over? I said, I don't know, but the FDA tells us to be concerned for at least 5 to 15 years. The same is true for myocarditis. The same is true for cardiac arrest or potentially cancer. What we're telling you is Americans have taken on now a whole new multi-year concern, a health concern, after taking these genetic vaccines.
And on that note, we were advised that at 2:30, we need to be done with our business. It appears that there is some kind of something planned that we're going to be needing to leave the building around 2 o'clock, I think. So maybe a little change in schedule. Maybe Dr. Hale, would you like to go ahead and enlighten us to your experience? And we'll go ahead and continue our discussion, and then we'll gavel out and have lunch afterwards, if that's okay with everyone. Can everyone survive waiting to eat?
Okay.
Okay. Thank you, Senator Carroll.
So once again, I'm Steve Hale. I'm an emergency room and ICU doctor, and I'm very honored to be here today. And I just wanted to read a quote. "If I've seen further than others, it is by standing on the shoulders of giants." And I just wanted to say that when I was going through my COVID crisis of trying to figure all this out, luckily, doctors like Dr. McCullough, and I didn't know Dr. Bowden or Apter yet, but I was able to listen to him on podcasts before they were wiped out by YouTube and all, and gain some help to allow me to get through this. Besides reading the articles, you like to have somebody who's on your team and you can relate to. So I wanted to thank you very much for that. I listened to a lot of things that was important to me. So we're here talking about a disease that we have been trying to treat and try to get things done, but I just wanted to mention another disease first. And when you have compelling treatments with evidence that's done by randomized controlled trials, observational studies, case studies, what stopped us? Why could we not do this? I wanted to read just something just real quick. "There must be no barriers to freedom of inquiry. There is no place for dogma in science. The scientist is free and must be free to ask any question, to doubt any assertion, to seek for any evidence, to correct any errors. Our political life is also predicated on openness. We know that the only way to avoid error is to detect it, and that the only way to detect it is to be free to inquire. And we know that as long as men, we are free to ask what they must, free to say what they think, free to think what they will. Freedom can never be lost, and science can never regress." J. Robert Oppenheimer, 1949. I had to think when I was asked to speak here, how do I find a way in? These very prestigious people that have been through a lot, they've lost a lot, they've sacrificed, very courageous people. I'm a frontline worker. I found when this first started, my only job at that time was in the intensive care unit. We hit the wave of COVID in about February, I'd say, in my hospital. I was reading everything I could, listening to Mayo webinars, listening to everyone I could, because my group that we met with, they were looking at the WHO, NIH, CDC, and there was no answers. There was no treatments. People were coming into the hospital, very low oxygen, marching right onto a ventilator. At that point, we didn't know what we were doing and putting a lot of people on ventilators early, and they would usually die slowly, not real quick. Quickly learned ventilators were not the way to treat the hypoxia, the low oxygen. And then we used methods that were non-invasive, high-flow oxygen, we called it, and to try to keep people off a ventilator unless their oxygen got into like low 80 range. Everyone in this room here is 95 or better. I don't see anybody with oxygen on. So we were letting people drop very low because we realized that was the way to try to save their lives. But we weren't giving steroids early because we thought that might cause infections. We weren't anticoagulating people, although we saw early they were clotting. So we had the hospital protocol which basically, originally when you came in, was Tylenol and an oxygen or a ventilator, and that was pretty much it. Fortunately, FLCCC came out, and Dr. McCullough is part of this. We were able to look at things that we could add. So we added steroids, we added anticoagulants, blood thinners. Besides that, it was vitamins, vitamin C, D, zinc, those kind of things. And then lo and behold, hydroxychloroquine popped up on the drugs that we were available to administer. Shortly thereafter, the hit piece from the Lancet Journal came out, and it was just a terribly fraudulent study that I think a first-year stats student could have picked up all the problems with it. Had a large number of patients, but it was totally bogus. But that locked in, and we stopped using it. And then shortly after that, New England Journal came out with an article as well. So hydroxychloroquine, after, I don't remember if it was a few weeks or a month maybe, but that was taken away from us based on fraudulent data and studies. We, after that, were able to get ivermectin for a short time. Ivermectin was being used, I would say, successfully. I remember particularly one story very well. I was talking with Scott, our pharmacist, is here about it the other day. We had a 400-pound person who I would talk with the hospital. Actually, besides me in the whole hospital, there was one other doctor that would use ivermectin besides me. That was it. So she called me and said, I have this 400-pound guy, but the dose on this is absolutely astronomical. What we'd have to give him in pharmacy is having trouble with it. We talked about it, gave it to him. He was in dire straits. I believe in 2 days he was discharged from the hospital.
400 pound.
Isn't that right, Scott? Yeah, he was heavy. He's
God bless him. That's incredible. I'm sorry. I'm sorry to interrupt you.
No. So we had a few stories like that, and then as time went along, it was removed pretty quickly from formulary. And at that point, I would have to talk with family members and tell them, you'll have to go to administration and threaten them with a lawyer, because I had tried every avenue I could to get ivermectin to patients in the ICU, and they wouldn't dispense it. The pharmacy wouldn't give it out. Interestingly, some patients pushed hard enough that they were able to get their family members a few doses here and there, but for the most part, family members did not get lawyers, and it did not become a legal battle. And then my position switched to a night doctor, so things kind of got from there difficult because I had two jobs. So I'll just say that I wish I could have pushed harder. I wish I could have done more to keep ivermectin on the forefront, but I was not able to do that. So basically my time in the ICU was spent on these protocols with remdesivir. And as you've heard me say before, I would stop the remdesivir and then it would come back on. I tried to have conversations with my group about why we would do things that don't make any sense. Everybody was bought into the WHO, CDC, NIH, Fauci, that story, and there was one or two other doctors out of the 30 there that would support me. So it was very lonely. It was a hard time. I was also unvaccinated. So that didn't help. I was a misinformer about vaccines, and I remember particularly getting into it I was in my ICU position, but came down to the emergency room about a patient who was needing to go on a ventilator, and I told them, wait, don't do that yet, let me get down there, and overheard the emergency room doctor telling him, see, this is what you get for not getting vaccinated. You're going to go on a ventilator, and you're probably going to die. I've been around a long time, and I never heard that out of HIV or anything in my career. So that was, and then, of course, they knew I wasn't vaccinated, so that would bring up these discussions, and I wasn't a favorite amongst the staff. And from there, I can just say that the protocols that we had were ineffective. You heard Dr. McCullough. I don't need to go into it again. It was very alarming that we weren't doing anything for these patients. Mortality rates were high. If patients got through it, it was just because of their tenacity and what they were built of biologically, because we weren't really doing much for them. I then started a job at the VA in the emergency department, which was interesting. There we had ivermectin for about a week that we could use, and then that was taken away. I was able to prescribe it for a short time outpatient, And then pharmacies were doing the same thing that you've heard from the others here. I had to find a compound pharmacy, the only one in the area that would prescribe it. Otherwise, no pharmacy would fill, and sometimes they would run out. So I was unable to really do that. Fluvoxamine is a SSRI drug that we were using to a great deal of efficacy, and that was taken off the table too. And then we gave this baby dose of dexamethasone. It's a corticosteroid for lung inflammation. 6 milligrams is low. I was giving higher doses and sometimes being called out for giving high-dose corticosteroids. And if you're going to treat an inflammatory disease, because COVID, by the time it got to us, the viral replication phase was gone. It was an inflammatory and hypercoagulable state, meaning you had to give corticosteroids and you had to anticoagulate these people, meaning blood clots in the lungs and all over in the body. And then to make it worse, let's add remdesivir and put them into kidney failure. So those were the challenges at that time. And I forgot to mention about the pulmopiravir that's used to treat equine encephalitis. Does the FDA know that? But so there's other drugs out there that are used for veterinary reasons as well. Paxlovid came along, and we were all instructed patients will be coming over to the emergency department by request of their primaries because they don't really know how to prescribe it. They wanted us to prescribe Paxlovid. I think I'm the only physician who's not prescribed Paxlovid where I work. After informed consent, which I do with a vaccine, I don't administer it, but I go over it with patients. All drugs are vaccines, the risk and the benefits. And I've not had one patient ask me for Paxlovid after risk and benefits were discussed with them. I prescribe them ivermectin if they'll take it or if they want it. If not, I tell them you're better off on your own. You've heard Dr. McCullough, rebound, it may promote infection, other problems with it too. And plus at the VA, if someone wants to get it, they have to get kidney and liver tests because of the potential damage. So I've had to battle that one and work on the front of being the only doctor who doesn't recommend vaccines and will not give the current medications there that are being requested of us. I'm still gainfully employed. I am able to treat people, I think, effectively. I think my greatest service that I provide is the informed consent, which I don't know how many people who've got vaccinated ever got that. Most patients or people I talk to who've gotten their first go around were never given informed consent about these vaccines. They were never told. Every day when I work, I make risk-benefit decisions at the bedside with patients about medications and other things, and vaccine is right up there with it. There is no reason, you heard Dr. Bowden say, there's no reason that I can see at this point for anyone to get a COVID vaccine. I don't see any benefit at all, only downside from it. I read my medical journals mostly now for fun, jokingly. They're still recommending vaccines, Paxlovid, things like this. My naivete in this, in the course of all this, enlightened me a bit about the medical journals. At first, when I went into medicine, I thought these are trustworthy entities. You read them, you'll get all of the data that's accurate, and these are true studies. Vioxx is a drug you guys may have heard about in the past that killed over 60,000 people. That was Merck hid data about that. But now we're in another phase where all the medical journals essentially receive funds from pharma and are pharma-owned. If you want to read a good book, Dr. Marcia Angel wrote a book about this in the early 2000s. And she was the editor-in-chief of New England Journal. Back then, pharma owned the big journals, and it's no different now. So, just summarizing, I think we've lost trust in the medical community, the medical organizations. We're not receiving accurate information. We're not receiving the truth about medications, vaccines, and about our health care. And we have to take it back over. I can't say anything more than Dr. McCullough said. It was said excellent over here. This is a battle. This is a war. And we've got to come out, and we have to start speaking up. You have to talk to your friends and family members. We're not at the point, people are becoming enlightened. We're not at the point yet where there's enough of us out there that can change this right now. don't be fooled by what's happening right now, that we're going on a path that's eventually going to get us there. We really have to speak up and say more and be active.
Let me just give some color on why the medical literature is filled with papers showing the vaccines are safe and effective. That's the conclusion of the paper. In fact, in the papers usually start out with a phrase like this: COVID-19 vaccination has been essential in managing the pandemic. It usually starts out with that premise. Here's the reason why. The vast majority of research papers, clinical papers, come from medical institutions like medical schools or health systems. President Biden mandated that all doctors, nurses, and healthcare workers at these institutions get vaccinated.
Yep.
So all of the institutions were, in a sense, promoting the vaccine. They all took the vaccine. Some estimates are about 94% of doctors took the vaccine. So if there is a manuscript pointing out a safety problem with the vaccine, and the doctors actually get together and make these observations, write the manuscript, it still has to get approved by the institution before that manuscript goes out the door. And I can tell you, these manuscripts are not going out the door. I think the doctors themselves and the nurses are having a tremendous time psychologically handling what's happened and what they've taken into their bodies. Many of them, if we bring up this conversation in the hallway, the most common thing I hear is, I don't want to talk about it. That's the most common thing I hear. Don't want to talk about it. To make matters worse, there's all kinds of methods that are being used to, in a sense, intentionally make the vaccines look safe. So the best example is vaccination during pregnancy. It's been time-honored that pregnancy is a natural, robust, super immune state. Pregnant women are not immunocompromised. They actually have robust immunity, especially with COVID. There's a manuscript in Annals of Internal Medicine by Pinellas and colleagues that showed that pregnant women have much better outcomes with COVID than non-pregnant women. So it's actually a great thing to be pregnant. The FDA, with the clinical trials of Pfizer, Moderna, Janssen, and Novavax, strictly excluded pregnant women from getting a shot. The FDA and the institutional review boards knew it was dangerous for pregnant women to take a shot. We had no idea what the blood clotting capabilities of the vaccine would do to the placenta or the baby. We had no idea if the genetic material would be passed to the baby or the spike protein. Now we've learned in recent studies the messenger RNA does go to the baby, and it's been horrifying to find this out, that the messenger RNA goes through breast milk to the baby. All been found out afterwards. So in the first week of the vaccine campaign, I was alarmed to see pregnant nurses getting vaccinated. I thought for sure they would follow FDA regulations. If a population is excluded from clinical trials, there's no way they're going to get the product with no prior information on safety. In fact, first week of the campaign in the United States, over 3,000 pregnant women took the vaccine. Now there's 30 manuscripts saying the vaccines are, concluding the vaccines are safe in pregnancy. The vast majority of them don't even monitor a woman for 9 months, so we don't even have a full term. Certainly don't have any outcomes with the baby beyond a delivery. And many of these manuscripts will say, well, if there was a problem and they didn't come back to our hospital, we didn't capture what's going on. I can tell you the vast majority of women who deliver at a big hospital, they have a complication. A lot of times they go elsewhere. So those aren't captured. And they all come from institutions that mandated the vaccine. So there's one paper by Thorpe and colleagues, I'm senior author, that compared the COVID vaccines in pregnant women to the influenza vaccine, which is administered during pregnancy. And we found astronomical rates of fetal loss in the first trimester, miscarriages, stillbirth, 20 weeks and beyond, fetal demise at the time of delivery, maternal hemorrhage, and fetal hemorrhage. So the question on the table is, do you trust the 30 manuscripts from vaccinated doctors and institutions that would only allow a favorable manuscript to go out, or do you trust the one independent manuscript? And I think now's a time for discernment, for people to look for independent views on what's going on. Because there is harm going on. Common sense tells us do not use a novel genetic technology with a dangerous mechanism of action and no assurances on safety in a pregnant woman. Do not risk a pregnant woman's life or that innocent baby's life. And yet that happened wide open. Now a FOIA has come through, and we found out that the American College of Obstetrics and Gynecology in the spring of 2021 took millions of federal dollars to push the vaccine on pregnant women. It was a corrupted bribe. It's a corrupted bribe with no information on what was going to happen to the baby or the mother. Everyone should look at pregnancy as this special example. I know it was a crisis and it was a time of emergency and confusion and lockdown. But everyone should look at that and ask the question, how? How could the entire FDA, the National Institutes of Health, the CDC, and they said, you know what? They said vaccinate the women anytime during pregnancy. Anytime. Doesn't matter. We now have, in a paper by Hoyert and colleagues from the National Center of Health Statistics, record maternal mortality. Starting in 2021, it's going up. It's erased 4 decades of progress in obstetrics. Pregnant women are dying with the baby in the womb. And the U.S. National Center for Health Statistics considers a maternal death during the 9 months of pregnancy and up to 42 days afterwards. And in that manuscript, there's no mention of COVID and there's no mention of the vaccines. They're simply reporting this bad news that pregnant American mothers are now dying at alarming rates. This is in a U.S. federal government publication. I think everybody listening to this should be alarmed.
Absolutely. It's horrifying. Dr. Hale, you mentioned informed consent. When you gave informed consent, or they don't often get the vaccine. They don't often move forward with Paxlovid. They don't often move forward with that. And I think that that goes to what we're discussing. When we talk about informed consent for the vaccine, how can you have informed consent when you have no data? So where does the responsibility lie?
Well, you know what's interesting about this too is before I came here, I thought, let me ask some of the nurses and doctors I work with, what was it like when you got the vaccine? Were you given informed consent? Did anyone, and no one can remember having anyone review with them anything about the vaccine. Just sign this paper and roll up your shoulder, but no one spoke to them. No one can remember having a conversation. We do this for well, I have to tell you, we do this for surgeries. We do this for all medical procedures. We go through the risk and the benefits of everything that we do for a patient. This is, of course, no different. With a medication, it's the same thing. A new medication that has a black label warning, meaning it can cause death, that's Paxlovid. EUA, emergency use authorization as well. So the informed consent goes something like, you would tell a patient, this is your condition. Can you repeat back to me and tell me if you understand the severity of your illness or what's happening? And then this would be a benefit of taking this. And then I ask them to repeat it back and make sure they understand. And then the risk of it. And by the time you go through this conversation and you give them you have to give them truthful information, by the way. You have to tell them the truth about the vaccine and about these drugs. You can't tell them what the drug company says, which is basically what they're hearing from their providers, because doctors, I don't want to call them lazy these days. And I'm not talking about everyone. I would say doctors are rushed and busy and don't take the time to really think about where did all this information come from. Did they really look at the article and the methodology and critically evaluate it? I think most doctors today just go right to the abstract oh, this article said the vaccine's safe or Paxlovid works. You need to look at the methodology as a doctor and see how it was done and critically be able to review it. I don't see that being done anymore for the large part. So if you give truthful information to patients, like I say, let's face it, I'm biased. I don't believe in the vaccine. I don't believe in the drugs that are out there for it. I do try to present as honest evaluation of that situation as I can, as I've always done in my medical career. But that's what it looks like.
I'd like to ask all of the doctors up here, how were you taught about informed consent? What was it that you were taught? When was it taught? And why, when they taught it to you, why was it important? Why were they saying it was important?
I actually published a paper on informed consent in residency, and at the time I thought, gosh, this is just not very interesting, and because it was over sinus surgery. When you do sinus surgery, there's a risk of damage to your eyes and to your brain, and most patients don't really realize this. They think, oh, I'm just getting my nose cleaned out. They don't realize how serious it could be. And so we did a study looking at, okay, do patients really want to know this? Like, how much do patients really want to know? And we were actually surprised. Well, yeah, they want to know it all. They want to know every single piece of it. So, if you compare what happened with the vaccines to surgery, I mean, you wouldn't just I would never march in the operating room without discussing what could happen with the patient in advance. You would never do that. You'd lose your license for that. And yet with the vaccine, it was done left and right.
I like that you bring that up. I have a bill that has not been very well received this session, and all it is putting the provider's signature back on surgical consent forms. Because over the years, as I've traveled around the country, I noticed that I'd get to cities that the provider's signature's gone. I mean, I'm the nurse that would chase the surgeon down the hall. Hey, I need you to sign this before I can roll back. Even if they get mad at me, I don't care, because if you don't sign it, right? If it's not documented, it's not done. I mean, that is just simply something we say all the time. I mean, you're getting I don't want to say in trouble, but investigated for not documenting, right? So I mean, that to me, without a signature, it wasn't done. And so I was kind of intrigued at the pushback that I got on that this session, just wanting to put the provider's signature back on a surgical consent. So, Dr. Apter, do you remember when you were taught about informed consent and what it meant?
Well, I think I have to say I don't really remember. It was probably 100 years ago. But I think one of the big problems in American medicine today is that so many doctors have become protocol doctors. There's been this enormous proliferation of guidelines and protocols. And I used to think those were based on the best science in the world, but I think like the other doctors here, we've come to realize that, the doctors on the panels creating these guidelines are heavily dependent on big pharma for their living and their salaries, and the papers are very, very biased. The medical journals are biased, so all the guidelines are biased. And yet, with the proliferation of these guidelines, doctors are forced to follow them. With the corporatization of American medicine, they're either hospital employees or hospital system employees or large corporations that are physician staffing organizations, and they're forced to follow these guidelines, and it's monitored through these electronic medical records. So they're graded and often compensated on how well they follow these guidelines. Plus, with the proliferation of them, they don't have time to look independently at the research or consider independently the individual patient. It's already too burdensome just to keep up with what the guidelines say, let alone to try to figure out what's behind those guidelines. So I think the practice of medicine, the art of medicine, is dying because doctors are not allowed to look at the individual patient, consider the individual patient, can put together the knowledge and experience they have, and create a program that's individualized for the patient. So I think if your doctor is telling you just follow the protocol, I think you need to look elsewhere.
I want to point out that currently Pfizer and Moderna and Janssen, the current vaccines on the market, are now FDA approved. There is now a package insert. So I'm just looking at the one for Moderna. Okay, now these were approved. The current ones in use were not initially tested in humans. They were just tested in a few animals and released on the market. And they were relying on the predicate information from the prior versions of the vaccine. But the current Moderna package insert, so if you're going to have a full informed consent and read the package insert, does not mention death as a potential serious adverse event that occurs with Moderna. Doesn't mention that it can happen. There are nearly 4,000 papers on safety of vaccines, COVID vaccines, in the peer-reviewed literature, with many cases and case series of fatalities. The manufacturer and the FDA is completely ignoring the possibility that one can die after a vaccine. And even if there was an attempt at full consent and someone's to read the package insert, they're deceived by this document. Now, as senior author, I've just published a paper in the European Society of Cardiology journal, a very good journal, describing the autopsy findings of patients who die after vaccine myocarditis. The heart inflammation that occurs from the vaccine. The FDA says this heart inflammation can occur. In fact, myocarditis is in the package insert for Moderna. But Moderna doesn't tell you can die of myocarditis. And in fact, the cases of death with myocarditis that happen after the vaccines, it's relatively sudden. In our case series, no one had a chance to get an MRI or get the diagnosis ahead of time. They die and then they figure it out afterwards at autopsy. 100% of the time, it was fatal myocarditis. We didn't find another explanation for why they died. They took the shot, and within a few days, they died. So, and this is in the peer-reviewed, published literature now, which is coming under attack to actually get these papers retracted off once they've actually published the truth. So I can tell you the deception now is full force. It's multi-level. From the US FDA, the regulatory agencies, the academic institutions publishing, the pharmaceutical companies, all the way down. It's all the way through. It is truth that people can die from the vaccine. I presented the US data. It looks like a large number of Americans have died after the vaccine. And yet the consent form, which would link to the package insert, doesn't state that could happen to the next person who's approached with the vaccine.
Do you know the origins of informed consent? It's my understanding that informed consent came out of the Nuremberg trials in Germany after the Nazis were experimenting on humans without their knowledge. So there's been the, oh, you guys are just a bunch of conspiracy theorists, and what's funny is that I don't really see how it's a conspiracy that people are being experimented on without their knowledge if there is no information. And they're now publishing myocarditis can be a side effect of this vaccine, but do not put that myocarditis is deadly. It's not that hard to follow along with that. It's very simple. Am I incorrect in my understanding?
No, that's correct. Yep, absolutely. I just want to say one other thing about, I'd like to hear the other doctors' experiences here. I can't tell you how many times a patient will come into the emergency department, say, oh, I feel like I have the flu or COVID, but I can't be COVID, I just got vaccinated. And I would say probably 80% of the people I see now with COVID are vaccinated. It doesn't seem to be a lower respiratory tract problem anymore, so it's more of a lighter kind of infection now. But the vast majority of people I'm seeing with COVID now have multiple vaccines and boosters.
So we've spent so much time on the safety of various products used in the hospital, suppression of treatment, of things that doctors found to be useful and that had signals of benefit but acceptable safety, and now safety of the vaccines. But we always consider safety first. It wouldn't matter if these vaccines really worked or not. If they're not safe, they shouldn't be used. This is very important. Safety comes first. Safety, safety, safety. We have consumer product protection laws in every state in the country. We have a culture of safety, from driving to food to other pharmaceuticals. But with these vaccines, there's a willful blindness to safety. Now, it turns out in terms of efficacy, the original trials did show a reduction in new cases of COVID. No reductions in hospitalizations and deaths. But within a few months of the vaccines coming out, thousands of fully vaccinated people were being hospitalized and died. And these were being reported to the CDC. And the CDC was putting it out on their website. May 1st of 2021, the CDC said, we give up. We just have too many vaccine failures. We're not going to report this anymore. So the CDC knew that people could be fully vaccinated, still get COVID, and die. By the summer of 2021, our CDC director came out and told America the vaccines don't stop transmission. There was plenty of cases of fully vaccinated people transmitting it to fully vaccinated people. It was about 2 months after that that the NFL, the football league, mandated the vaccines on the players. So most of the mandates, the people mandating them knew the vaccines did not stop transmission of the virus. The only reason why a mandate could ever be thought of would be to actually try to protect the workplace or protect people there. But a vaccine that doesn't stop transmission can't possibly protect anyone. So something got way off track in people's minds. I'd love to see some hearings of people who were really responsible for the mandates. The NFL, they weren't healthcare workers. They didn't have to do this. I'd really like to hear, understanding this, that when our agency comes out and says something, that everyone just ignores it and they put the mandate in to begin with. Now, in terms of efficacy, once the vaccine failures came in and our CDC admitted that the vaccines don't reduce transmission, then we started to see the wholesale failure of the vaccine. So any country that had a fair assessment of vaccine status was reporting way more vaccinated people than unvaccinated people in the hospital sick with COVID and dying of COVID. Shretha and colleagues from the Cleveland Clinic had 51,000 Cleveland Clinic workers, and they published their analysis. The unvaccinated had the lowest rate of recurrent COVID, and that with each shot, a worker actually got more and more cases of COVID over time. 51,000 people, and it's really well categorized in the database. And now we have a situation where the most recent genre of vaccines have no human data whatsoever, no safety or efficacy data, just animal data, and they're put on the market. So each time the genetic code changes for the spike protein. And with the bivalent vaccines, people actually got several different types of spike protein produced in their body. And now we're back to monovalent vaccines. Each version of the vaccine is way behind the current substrain of COVID-19. So on a mechanistic perspective, it would have no chance of being beneficial. Americans aren't fooled. The current rate of anybody taking a vaccine right now is about 15%. And I think that, sadly, those who are taking the vaccine aren't doing it for their health. They're doing it because they're told they have to do it for work or some other reason. And I recently conducted a Twitter poll, and it was last fall, and I said, does anybody, at the time we were on the 7th shot, I said, does anybody know anybody who's taken 7 shots? And I was shocked with the response. I had thousands of responses. The answer was about 9% of people who responded were actually on their 7th shot. I said, well, who are you? And the answer is, we're Canadian healthcare workers, or we're European healthcare workers, or what have you. There are countries still to this day where the healthcare workers have no choice outside of take a shot every 6 months, reluctantly. And they know how dangerous this can be. There are plenty of case reports now where people tolerate the first 5 shots and then the 6th shot is fatal. The shots don't appear to be the same. US CDC analysis, Ron Johnson had performed this with some help, submitted it to the CDC and FDA, and now Schmeling and colleagues did it in Denmark, showed that about 30% of the vials, people have no side effects whatsoever, none. They don't appear to have any side effects. Slightly less than 2/3, there's some modest side effects. And in the Schmeling data, it was 4.2% of the vials. That's where the serious side effects were, including fatal ones. In the US CDC vSafe data, 10 million Americans participated in this. The rate was 7.7%. People got so sick they had to go to the ER or urgent care. It's US data. So the Denmark data and the US data relatively agree. We're not acutely worried about everybody right now, but it's 5 to 10% of people we're really worried about. But 5 to 10% of a big number means a big number of people who are coming forward with blood clots, myocarditis, stroke, hemorrhage, vascular dissection, various what's called vasculitic problems, immunocompromised problems, renal failure. So this is still a big point. I want people to understand, though, that there's a reasonable chance that people who took the vaccine, some people who took 1 or 2 shots had no side effects, is a reasonable chance that they're in the clear. We still have this 5 to 15-year worry period, but a lot of people stopped after 2 shots in 2021. They really took 2 and they said, listen, this doesn't look good, I'm not taking any more. We're watching people carefully, but I always ask, did they have any initial side effects? Because if they didn't, that's a good prognostic marker.
Adult onset sudden death, or sudden adult onset, this is a new disease that came out, right? I mean, we've all known about SIDS. I think every parent in the room has all known about SIDS, and everyone has, we're going to do co-sleeping because we're scared of SIDS. So what do you believe where did that stem from? Did that stem from we just need to put it under some kind of label? We don't want to truly expose what it is?
The term sudden adult death syndrome arose because people who took the vaccine were having cardiac arrests really without any premonitory symptoms. And there was case after case after case that was occurring. So Holscher and colleagues from University of Michigan, as the senior author, as the first author, I'm the senior author, collated every single one of these cases that died and had an autopsy done. And what we found is 73.9%, when we re-adjudicated all the findings, had the vaccine as the cause of the sudden adult death, or it considerably contributed to the causal pathway to death. So as we sit here today, the next person who dies with no antecedent fatal illness, with no explanation, and you see it or you hear about it, the data suggest on a more probable than not basis, it is the vaccine that's the cause of death. It's not a mystery. So this is a very important paper out there. We took incredible stakes to make sure we didn't miss any cases. We did a standard Prisma search design. We had standard adjudication processes in place. People experienced with cardiac pathology. Most of the deaths that occur in the sudden adult death syndrome are cardiac. There is a fraction that's due to blood clots, and blood clots are well acknowledged to be caused due to the vaccine. And then smaller percentages due to other organ injury system illnesses.
Okay. So now I'd like to shift a little bit. We've talked a lot about early treatment, but I'm very fascinated with, Dr. Corey is really kind of the one that's been sounding the alarm that I'm seeing, and that is talking about vitamin D. And vitamin D levels and how important that is to our immune systems, and how we found that to be so important in the treatment of COVID. And still to this day, I find it interesting that hospitals are not utilizing a protocol of something as simple as vitamin D. Now, many of you have heard me say that I kind of threw the red flag on the field early on in COVID when I was put in Facebook jail for 30 days because I, as a nurse, prevention is all I think about, right? So I put out a post saying, make sure you're getting plenty of sleep, and make sure that you're eating healthy. Make sure that you're taking at least a daily vitamin. Get outside in the sun, get some sun on your skin. And we know that the UV rays, and the reason why has to do with the vitamin D. But I find it interesting that I got put in Facebook jail for that. You want to talk about censorship? That's a little interesting, but it's a conversation that that's happening more and more. And I know that there is a study that is showing that Americans are at extremely low levels, just across the board. And that makes us, I think, a little bit more susceptible for all of these diseases, does it not?
So something that's, there's many positive things that have come out of the pandemic. And one of them is our understanding that vitamin D seems to play a vital role in immune support. And doctors and nurses and other people started to figure this out through the pandemic. So there were a multitude of small studies done and larger ones done all over the world. And a standard dose for supplementation for over-the-counter vitamin D3 would be 5,000 units per day. Previous studies in osteoporosis used 500 units or 1,000, very, very low doses. But I'll just update you with a paper published very recently by Sartini and colleagues from Italy. And there are now 16 studies, and this was very, very carefully done, 16 studies of vitamin D supplementation done before the onset of COVID, before actually getting COVID. So this is intentionally prevention. And they found that there was a 60% risk reduction with vitamin D alone. And there was a 69% reduction in the need for ICU. If someone got sick, need to go into the ICU. And these studies are joined with a broader complement of studies, observational studies and others, that showed at any phase of the illness, either prevention or active treatment, vitamin D played a role. And I can tell you short-term vitamin D has essentially no toxicities, even at higher doses. So again, the question on the table would be, why wouldn't the hospitals administer this to patients? Why wouldn't this be a public health initiative that our National Institutes of Health could get behind as a simple measure? If you look at the things that anyone would consider completely safe, it would be nasal sprays and gargles, vitamin D, vitamin C has some supportive data, zinc, a supplement called quercetin, an over-the-counter safe drug, famotidine, all of which has supportive data. Why not support a cocktail that's simple, affordable, and no one could be harmed? In fact, our government guidelines and others around the world actively advise against most of these measures. For instance, famotidine, in a University of Virginia study by Mora and colleagues, 20,000 people were studied. Famotidine, over-the-counter Pepcid, because it has an antiviral effect, had about a 55% reduction in risk of hospitalization and need for the ventilator with COVID. Famotidine did. Famotidine. Now you could argue, well, these aren't large randomized trials that are placebo-controlled, that are, that have a sponsor bringing them forward. But this is a time of great need in our country. And, whether the real rate is exaggerated through observation or not, it doesn't matter. Those who took famotidine, they survived. Those who took vitamin D were more likely to survive. So when you think about this, the Institute of Medicine put out a statement years ago that said there's a linked legislation. It's called the 21st Century Cures Act. It says, listen, when we're confronted with a crisis like this, all the information counts. The randomized trials, the observational studies, the mechanistic studies. Everything's on the table. Do you know that a Cochrane analysis, when they analyzed what had been learned from randomized trials and what had been learned from observational studies, they largely agree. So a randomized trial, and I love randomized trials, I've done them my entire career, they take about 2 to 5 years. And for something to get in the guidelines, it takes multiple randomized trials. Typically, a product that actually works could take 20 years to get in the guidelines. We didn't have 20 years. We had people, Americans, dying. We needed every bit of innovation. And when I published the first version of what's now copyrighted, the McCullough protocol, but it was published in the American Journal of Medicine, the rules that I used was, listen, people are dying. We want drugs that have signals of benefit, a hint that they're going to work, and have acceptable safety. We're not going to rely on a single drug, put drugs in a combination, and use them and make careful observation on what was happening, because medicine is both an art and a science. And I did that within an academic institution, I partnered with a community physician. We published the best studies we could, and we demonstrated roughly an 85% reduction in hospitalization and death with a multi-drug protocol. And other doctors did it around the world. But I think one of the most interesting observations that two doctors, one Eugenia Barrentos from El Salvador and Dr. Sankara Chetty from South Africa, they demonstrated that you didn't need hydroxychloroquine or ivermectin, that no drug was actually necessary nor sufficient. They used a different combination of drugs. That's the reason why in my protocol I offer choices. You know, Paxlovid is a choice, but so is ivermectin. We should have always had choices of drugs at these different levels. There's choices of anticoagulants. There's choices of nutraceuticals and supplements. There's choices of nasal sprays and gargles. But boy, we ought to do everything in a package, a protocol. And if we ever have another pandemic or a severe case of flu or respiratory syncytial virus or disease X we're warned about, we better have an all-purpose multi-drug protocol that people can go to that makes sense. And everything that we've put together, largely we're talking about, would work for many different viral illnesses. So please consider that going forward. If we've learned anything, do not take the advice of sitting home and getting very sick and go to the hospital. The hospital failed us in the COVID pandemic. They're likely to fail us on the next one.
Prevention, prevention, prevention. Yes. Dr. Hale, what was your experience with vitamin D in the ICU?
Well, we gave it. Even if patients were on breathing tubes, we would give it down a feeding tube. So I'm thinking back at least 5,000, if not 10,000 international units. Zinc, of course, vitamin C. We also gave melatonin, fluvoxamine when we could before they took that off. And what I do when I see patients in the emergency department, what you just heard from Dr. McCullough, that's what I tell everyone for whatever viral disease they have to do these preventative things, because the ivermectin's not something I'm able to give, but like Dr. McCullough suggested, it seems like these things are working quite well now to give the preventative measures that were just mentioned.
For all respiratory viral infections?
Well, that's what I'm doing, because and in fact, sometimes now when patients come in, it all seems like it's the same thing, and we only test for 4 where I am for the influenza A, B, RSV, and COVID, and sometimes it's possibly something else. So I pretty much tell them all the same thing.
Okay.
So on the vitamin D, I think it's useful to, if patients can, to get their blood levels checked for vitamin D. And interestingly enough, if you go get the lab test, the normal is reported as anything above 25 or 30. But we're finding that really it should be at least 50, or I recommend 60 to 100. And there have been good studies published that showed a pretty direct correlation between severity of illness and COVID and what the patient's blood level of vitamin D was to start with. Now with vitamin D, it's a fat-soluble vitamin, so you have a large amount of stores in your body compared to the amount you take in daily. So most people, if they're taking it chronically, probably 5,000 units is enough, maybe 10,000 for some people. But if you're relatively deficient at the time you get sick, you need to get that level up right away. You have to take a large amount in a short period of time. So I recommend for my acute patients taking 40,000 units a day for 5 days and then dropping down to 10,000 if they don't have a level. And even if you do have a level, if you get your level today, if it's too low, you need a big boost to get it up. So that's an important thing to understand.
Is it beneficial to do like the D3 with the K2? Is that more, do you store more? Do you absorb more? Or does it not particularly matter?
I haven't done that routinely, but I think there are some patients that can't seem to get their blood level up with the usual supplementation, and then the vitamin K2 seems to help that. I wanted to say also about, Dr. McCullough talked about some of the inexpensive treatments that are highly beneficial. The NIH has a $50 billion a year budget, or something like that. That's a lot of public money that you would think should be going to study the nutraceuticals, the drugs that are off patent, and that the drug companies don't have a financial incentive to study anymore. The public money should be studying that, but instead they're studies are heavily in support of big pharma. Researchers that go against the standard narrative or risk losing their career for even suggesting that they study something else. So that money is being used to subvert inexpensive treatments rather than to learn more about them.
One of the things that if this was a debate right now in medicine, is people say, well, there's studies that show that ivermectin doesn't work or hydroxychloroquine doesn't work. 97% of Americans got COVID. The federal government spent billions upon billions of dollars. Every person in America could have been in a clinical trial. A clinical trial that would be sufficient to determine if something worked or not in a complicated disease like this would be 20,000 patients per arm, drug versus placebo. And within a few months, we knew it was a multifaceted disease, so we knew it was going to be a multi-drug problem. The types of studies we saw that were funded through what's called the ACTIVE program by our federal government were a couple hundred patients or a couple thousand at most, with very short durations of time. Sometimes we saw studies of a drug for 5 days. Patients were sick with a month or 2 months of COVID. 5 days of anything is a ridiculous standard to try to meet. We saw the clinical trials infrastructure of the entire country fall flat on this. There weren't any open meetings for people to come and give their ideas. In my field, we have what's called Bethesda meetings. We go to Bethesda, Maryland, and we meet with the NIH, the FDA, we meet with Big Pharma, and we have all-comers meetings. There was none of that. People were doing studies and publishing protocols. No one contacted us. The protocol that I published in August of 2020 in a widely read medical journal is still the most downloaded and read paper of that journal in the last several years. It became this bedrock standard for the Association of American Physicians and Surgeons, which is a fully chartered physician organization. That organization was never called by the NIH or CDC and say, wow, you've got a protocol, let's talk about it. What are you observing? How can we do clinical trials of the multi-drug protocol? How can we make it better? That association wasn't contacted by a single hospital or medical school in this country to say, can we adopt your program? Can you help us do this so we can keep patients out of the hospital? No one had an interest in saving lives outside of people and their families themselves and a small cadre of doctors. No one seemed to show any interest whatsoever. We saw the press quickly focus on the case fatality rate and then these horrible vignettes in the hospital, and then quickly we heard nothing after that. For the last 2 years, I can't think of a single major news segment that updated advancements on treatment of COVID or prevention of COVID. Nothing. The only thing I saw in news was largely advertisements on commercials. And the bizarre advertisement is the fact that HHS, the CDC, and the FDA are advertising vaccines. Our government agencies should never be advertising third-party products. That shows you that there's inherent bias here. There was an inherent bias from the very beginning for a vaccine-only strategy, period, with no mention of prevention or treatment.
And I think there's every reason to think that the whole vaccine program has greatly prolonged the COVID pandemic by evolutionary pressure to new variants. But if you looked at the data of cases with when there were big vaccine rollouts, look at it in a variety of countries, you see surges of cases shortly after every vaccine rollout. Well, how could it be stopping transmission if you get more cases all the time every time you put out the vaccines? That data is out there. The government, I think, has done everything they can to hide it, but that data is out there.
It's my estimation that if there were no COVID vaccines and we had a full-on early treatment multi-drug approach to this illness, that we could have prevented at least 2/3 of the hospitalizations and deaths, because it took us a while to learn how to do this. And we heard from Dr. Hale that we didn't originally know the benefit of steroids and understand that. By the way, we give much higher doses of steroids as an outpatient than what's given in the hospital. People go in the hospital, it's a step down in care. It's not a step up in care. But if we would have had a full multi-drug treatment approach for this illness, of which 97% of Americans got, according to my estimates, probably about 25% of the population would need treatment. 75% can get through it without really any active treatment at all, because it's a mild illness for younger people. We would have avoided 2/3 of the hospitalizations and deaths, and the pandemic would have been fully over with in 2 years, because we wouldn't have had the mutational pressure that Dr. Apter just told you about. The virus wouldn't have mutated. It mutated because the vaccines were in people's body, and the virus kept figuring this out, and the virus mutates. It doesn't exactly do that. There's actually always a population of viri, and then the one that's actually resistant is the one that becomes the dominant strain. When the Spanish flu hit the United States, 1918 to 1920, it was a 2-year experience. And it was a calamity for the country, but it was one that was only managed by doctors and nurses and the patients and families. From what I can tell, President Wilson at the time never mentioned the pandemic. Never mentioned the pandemic. It was a medical problem. COVID-19 should have only been a medical problem. Government intervention made it far worse in every aspect of the pandemic. It should have been in our wheelhouse, and then we could have actually policed ourselves and guided ourselves, and I think to a much better place. I think most doctors and nurses and healthcare workers, they want to do the right thing, but they found themselves quickly too far deep into this doing the wrong thing. And that's the reason why they're not here today to speak up for themselves. I've been to countless numbers of hearings. I've testified multiple times in Washington, and by invitation, not a single time did officials from the FDA, the CDC, the NIH come forward. Not a single time did a chief of medicine or chief of infectious disease show up on Capitol Hill and tell us what they were doing in the hospital was the right thing. Not a single time did any one of those doctors tell us that they've treated patients as outpatients and saved lives. And not a single time did any one of those doctors, I'm talking about every chief of medicine in every academic institution in the United States, and every chief of infectious disease, not a single time did any one of them come forward and tell us that the vaccines were safe and effective in their estimation. That should really be a red flag to every one of you. If these vaccines are so good, how come not a single official, chief of medicine in any department in the United States stand behind them?
Yeah, on the record, right? Because they're going to stand behind it as far as pushing the mandates and making sure that this is what all staff follows. As you're talking, there's so many things that go through my head, and one of the things that I remember is Representative Montenegro had said in I believe it was our very first hearing, that the more that we're looking into this, the more that we're realizing that when government does get involved in health policy, people die. And I mean, the fact that there's President Wilson was not involved in that pandemic, because we talk about the Spanish flu pandemic all the time when we're talking about COVID, and in the comparisons, I mean, that was the reason for the masks, right? Was that they utilized it, which of course the studies were corrupted. But I find it interesting that not anyone is coming forward to actually be a proponent. Dr. Bowden, what are your thoughts on vitamin D? What is your experience with COVID?
I don't have much to add other than I will say it is probably the most common lab abnormality I find when I test my patients, which is, and prior to the pandemic, I probably never tested my patients, so I found this very surprising. And then I will add one other thing that I advise my patients to get, because when things were really bad during the pandemic, nebulizers, doing breathing treatments at home would really make a big difference. That's like one thing that could keep people out of the hospital. A nebulizer is just a device that delivers medication to the nose and to the entire airway. You need a prescription for the medications, but because that was a delay. They were hard to get. I don't know if you were prescribing nebulizers too, but the pharmacies ran out. We tried to buy them and stock them, but that would be a sticking point where patients, and the biggest thing I hear is keep me out of the hospital. People are terrified to go to the hospital. And the nebulizer, I felt like that was one thing that could make it or break it for a lot of patients. Now, I'm not seeing, I mean, COVID's not what it used to be, right? People are not coming in with the lower respiratory tract infections. I no longer worry about my patients like I used to. Getting the nebulizer may not be, a huge importance, but, it's only a matter of time before something like this happens again. And that's one thing to keep in mind with these shots. They have opened up Pandora's box, and that mRNA is being used for every subsequent vaccine out there. So if we don't nip this in the bud, it's just only going to get worse.
Let me just add to that. People have asked, well, what happened to COVID? Best estimates are about 97% of Americans have had COVID. If you do blood testing for antibodies against the nucleocapsid and spike protein, almost everybody has it. If you look at the CDC wastewater data, most of the wastewaters actually has SARS-CoV-2 in it. The virus is still, highly prevalent in America. 3 things reduce the rate of hospitalization and death dramatically. 3 things. In Texas, the total number of deaths, even though they're overcounted and any test positive case counts as a death, we have 98,000 deaths. Only 1,500 of them occurred in 2023, and probably be much fewer in 2024. So the real risk of death is essentially over. But those 3 things are, the virus mutated to a far milder state. It's just a milder virus, which it characteristically does in a pandemic. The second thing is early treatment. It turns out in most studies now, anywhere around the world from 5 to 25% of people got early treatment. There's a paper by Roberts and colleagues showing that about 20% of outpatients got steroids as a proxy for getting treatment. So the good news is the early treatment message did get through. You talk to a lot of people that say, yeah, I got pretty sick with COVID, but I got some form of treatment. And then the third thing that really reduced the risk of hospitalization and death was natural immunity. Once people had the infection, the next infection is characteristically mild. So the single greatest thing you need to know is that when a loved one gets COVID and they tell you, I've got COVID, your first question is, well, did you have it before? Well, oh yeah, I had it 2 years ago. You can know that it's going to be a mild illness. But if they tell you, no, I've been careful and this is my first episode, if it's the first episode in a senior citizen, I still would take it very seriously and do a full multi-drug protocol.
Yeah, and if this was done right, if we had people who were looking at this the correct way, everybody would have been tested if you had symptoms for antibodies. And if you had antibodies, you didn't need a vaccine. So someone like me who would present my antibodies to the organization, and they said, no, you need to get vaccinated. I said, I want to speak to someone intelligently. Tell me why I need a vaccine with antibodies. And of course, there's no conversation in regards to that. The other thing I want to say real quick is for some responsibility upon ourselves is, and I don't want to offend anyone, but the vast majority of people that I took care of in the ICU were people with they have comorbidities, so lung disease, heart disease, diabetes, and obesity. And if we spent half as much money on this vaccine and what we've talked about today as trying to educate people, I know it sounds mundane, but eating right, losing weight, exercising. I got COVID and I didn't even know it. I was one of the asymptomatic people. I just thought I must have had it because I was around all these people. And I had antibodies. I think a lot of people who were healthier went through a milder course of it. And I think we could learn something from that aspect.
Yeah, it's a good point. That was something that I've mentioned many times in these committees, is that we weren't talking about BMI. We weren't talking about heart disease. We weren't talking about people that were diabetic, which sometimes goes along with a BMI over 25. So these are all the conversations we weren't having. And why weren't we having that conversation? Why are we not talking about preventing it? Why are we chasing it from the backside when that's not how healthcare is supposed to work? And it saddens me beyond anything that people have so much distrust with going to the hospital. But how can we not? And that's so sad and scary. And one of the biggest things that I found while my friend was in the facility here recently was that the culture within the hospital has shifted. People like me that would stand and advocate for the patient, what the patient wanted, or to advocate for, sorry, doc, I hate to call you and wake you up in the middle of the night, but we have an issue here. The culture of being a family member, growing up bedside, I mean, this is not what my mom wants. This is not what we're doing. All of that advocacy culture has now just kind of disappeared. Family members are afraid of being thrown out. The healthcare workers that are there are afraid of losing their job. They need their jobs. But also, I would say that they have an ethical feeling of obligation to be there to help people. And so that culture shift, that scares me. It scares me that government is so involved in this process now that government is now telling science what they should do. That makes zero sense to me. The government is not the expert, right? We're elected officials that we rely on experts for information, not the other way around. So the fact that shift has happened, that's where I think it's up to all of you watching. And those conversations need to happen. We need to make sure that the focus is on prevention, the focus is on good care, and being informed, because that's the only way that we're going to get through this in my mindset. I was alarmed to find out that my friend was not tested for vitamin D levels until day 6. His level was 9. Yeah.
So what you said made me think of Scott Atlas's book. So Scott Atlas and I were both writing op-eds by invitation in the Hill in the first year of the pandemic. Scott was mainly writing about lockdowns and social distancing and things like that. And I was writing about how the virus was spreading, the inaccuracy of mathematical models, and the importance of early treatment. According to Scott Atlas's book, is that once he was asked by former President Trump to be in the White House and advise him, Trump himself had already had COVID-19. He had actually already gotten an early version of the McCullough protocol. He had gotten some outpatient hydroxychloroquine, by report, antibodies, steroids, oxygen. He actually got through it fine. But according to Scott Atlas in his book, for months, all the discussion in the White House was on masking, social distancing, and lockdowns. Everyone was thinking about how they could avoid getting the virus. And in reality, everybody got it. So if we've learned anything with the next pandemic and a respiratory virus, we ought to assume we're all going to get it. We should assume we're going to get it, and what we're really preventing is we're preventing hospitalization and death. And I think everybody, if they could understand that, listen, it's not such a big deal to get a virus and get through it, provided we don't wind up in the hospital or die. So this idea of we're preventing hospitalization and death, that's the reason why exercise and the nutraceuticals and supplements, vitamin D, nasal sprays and gargles, it just takes an edge off the virus so we can get through it. But never again should we be in this mindset of, wow, we're gonna be able to dodge the virus. Everyone got it, vaccinated or not vaccinated. Everyone got it.
I don't think I ever got it. But I've also never been tested.
In the published studies where when people are tested with high-grade antibodies against the nucleocapsid and spike protein, there's one from the Harvard Framingham study database, as well as University of Texas at Houston, a big one. It's about 97%. So you will find an occasional person who just can't get the illness, but by and large, everyone got it. It's just a matter of if they had symptoms or not.
Yeah, I need to just take the time and go have an antibody test to see, but I never got sick. And I worked through the entire pandemic. Remember, I wasn't fired from my job until October of 21. So I worked all the way through it. And I work in the operating room, so every patient that I'm exposed to their airway. So just an interesting tidbit of information. So you have the antibodies but don't remember ever getting sick. So I'd be curious to see if I also am in that category and how many people are actually in that category.
Well, let's see a show of hands. How many people in the room have had COVID?
There's 1, 2.
Okay, let's see the opposite. How many did not get COVID? You did not get it.
But yeah, that's exactly right. We've never been tested, been sick, but never got tested.
Yeah. So there's like 5 or 6 of us in the room.
Yeah, I mean, but it's cohesive with what I said. There'll be a few people who truly didn't get it, and that's a wonderful thing. But many have been exposed to it, and they had a very mild case. Now, if we were to have a room full of children, I can tell you a lot of the children will say, yeah, they never had it, and in fact, they have had it. They just was so mild, you can't distinguish it from any other infection. But the distorted observation from the vaccine campaign is that the people who really could have benefited from a safe and effective vaccine were the 2.7 million nursing home patients and congregate living seniors and frail people in our country. Yet for the last at least 3 years, the incessant focus has been on people who would not need a vaccine: college students, the military, children down to 6 months of age. So even if we had a safe and effective vaccine, our public health agencies were looking in the wrong place to really have an effective program. You never see any focus specials on what's happening with the seniors in the nursing home, as if no one cares. But yet universities still to this day mandated the vaccine. Harvard just dropped their vaccine mandate. So that goes to tell you, the public health thinking, even if the vaccines were safe and effective, has been wrong. Why has it been so off?
Just real quick, Martin Kulldorff from Harvard, epidemiologist who was one of the writers of the Great Barrington Declaration, if you've all heard of that one, that argued for focus protection, just as like we heard over here, we didn't need to take the degrees of precaution that we did. But as soon as he saw what was happening and the reproductive coefficient, or the R naught, of something like 8 to 10, meaning for every person that gets infected, you're going to infect 8 or 10 people, he said everyone in the world is going to get this. So we just might as well start looking at other ways to handle this. Don't lock down. Don't try to keep people from getting it. It's going to happen.
So what that makes me think of, there's a study out of Japan, and I'm sure you know it, 25 years later, following now adults that never got vaccinated for measles are showing stronger outcomes, less cardiovascular disease. I found that quite interesting. Sorry, I do not have the capability to memorize studies the way that you do. So it was an interesting study that I came across not too long ago. So I have a few slides that I want to show that I was going to show in the beginning, but of course I got a little, this is personal for me in a lot of different ways that, and I apologize. Anyway, we're going to go ahead and show these slides, and then if everybody would like to just kind of make some closing comments, and we'll have this Senator Carroll and Representative Montenegro close with their comments at the very end, and then I do want your 2 cents, sir. Yes, sir. So if you would go ahead and show the slides. The first slide I find quite interesting, that this just came out from the CDC, and it says, it's official. We can pretty much treat COVID like the flu now. Here's a guide. So here we are, 4 years later. We're going to get rid of the website, even though nothing was ever put up on what we could actually do to take care of ourselves preventatively. And so now we're just going to treat it like the flu. So to me, I'm wondering, all right, so first of all, are we testing for both influenza A and influenza B and SARS-CoV-2? Are we testing for these, or are we only testing for one? Which leads me to my next slide. Does anyone else find it very interesting that as you go down through the years, 16 to 17, 29 million cases of flu, 0 cases of COVID, 17 to 18, 45 million of flu, 0 of COVID, 18 to 19, 36 million flu cases, 0 COVID cases. And then here we go, 2019, we have 38 million cases. Next year, 0.0015 million cases of influenza, but we have 32 million of COVID. Now, we can talk about that. We know that this was created in a lab. So we can talk about that's the reason why the 4 years prior we don't have any infection with COVID, at least monitored COVID, right? But does anybody else find it interesting that all of a sudden the influenza just went away? And as we move forward, I want to see the data as far as how is it going to lean? Is that going to flip right back and then continue to stay? And is that why the CDC has come out with it's just the flu? Next slide, please. There's been a lot of conversations along the way about all the things that they said. Multiple ongoing doses of the COVID-19 vaccine increases the immune system response. That was their theory. The reality that we know, herd immunity proved to be up to 5 times more effective than mass vaccination. Theory that vaccination is the most effective method of stopping the spread of COVID-19. Reality, research finds no increased immune system response with increased vaccination. In fact, we've heard testimony today that it's actually the opposite. Wearing a mask prevents the spread of COVID-19. That theory, that was thrown at us right from the very beginning. Wearing a mask may increase risk of contracting COVID-19. And I'm sure that there will be comments about why that is. I think there's been plenty of discussion of that. And the final one that gets me is please social distance, maintain 6 feet of separation. When in reality, individuals are no safer at 60 feet separation than they are at 6 feet. And when asked, Dr. Fauci did say that that was just a number, and that is on the record. I would like to close my thoughts on how much this has become an institutional disaster with the video that's at the bottom of that. Will that play, Katie? To me, this is the epitome of the broken. It might not play. There it is. There's the sound anyway. I think everyone in this room and the people that are watching most likely have already seen it. I'll just explain it, Katie. It is the video of the dancing nurses. It is a video that offended me and still to this day offends me because I think that it's absolutely the most heinous and cartoonish thing I've ever seen come out of any kind of healthcare institutions. And with that, I'd like to say thank you to everyone for being here. And please, Dr. Bowden, would you like to close?
Yes, thank you so much for holding this. It's very important that we keep talking about COVID. The pandemic is definitely over, but if we just let everything slide, before we know it, it's just going to get worse. I'm going to go back to my efforts to get more politicians to sign the pledge, and we also have physician organizations that are on this list. We also have county committees that have passed resolutions. There are 13 counties around the country that have passed a ban the jab resolution. And actually, Maricopa County in Arizona is on that list. So we just need to take that further, little by little, keep that effort growing, and then we need to pass laws to ban this jab because we do need to hold people accountable. But first and foremost, we need to stop the bleeding, stop these shots. They are being given to 6-month-old babies. It is wrong. Any other product would have been taken off the market a long time ago. Thank you.
Thank you, Dr. Apter.
Yeah, again, thank you, Senator Shamp, for having this and for inviting me to speak. I really do think we still need to ask, what is the agenda and who's behind it? How in the world did they get all the governments in the world, with perhaps the exception of some African governments, to go in lockstep with this agenda that has been so harmful to people all over the world, caused millions of unnecessary deaths? Some people blame Anthony Fauci, but others think that he's got his marching orders from the Department of Defense. Why would the Department of Defense do something that caused the loss of so many servicemen, either from resignation or disability? Well, who is behind it? I don't have the answer to that, but I think the question needs to be asked. And certainly the whole COVID vaccine program needs to be stopped, but our whole public health system needs to be wholesale reformed. And there needs to be accountability.
Agreed. Dr. Hale?
I'll start dark and then go lighter. We've misplaced our trust in authorities and have underestimated corruptness, censorship, and criminal intent. Science and reason have failed us thus far. And while the enemy seems insurmountable, I think as on the healthcare side, our obligation is always to the patient. It is always to you. We have to keep that in mind. Dr. McCullough brought it before, safety, do no harm. These are the things that we were brought up on in our careers, and this is what we have to do. We cannot fail any longer from our side. We have to step up and do the right thing. And I think that there's a good hope for us to do that.
Thank you, Dr. Hale. Dr. McCullough?
Thanks so much for everybody, for you in attendance and everybody watching online. And by the way, this is being broadcast widely on social media right now, so I can see the audience is huge. Everything that we've presented today in terms of our concerns on the suppression of early treatment, the lack of advancements in the hospital, and then unsafe and ineffective vaccines, everything that we've presented today is an underrepresentation of reality, because the biases are so strong against the truth coming out. Censorship programs in the media, gag orders in hospitals, restrictive orders to doctors and pharmacists not to do things. The reality is far worse than what you've heard today because of these biases. What you can do to take action is for you to actively engage in critical conversations regarding these three important things: the impedance of early treatment, the lack of advancement in the hospital, and the fact that hospitals didn't save everyone, and then unsafe and ineffective vaccines. Bring it up with your doctors. Bring it up with nurses and people in the waiting room. Let them know that you've heard and that you may feel that the vaccines are not safe for human use. Let them know that the Association of American Physicians and Surgeons, chartered in this state, has officially called for the vaccines to be removed from the market. So has the World Council for Health. So has the Florida Surgeon General, an MD, PhD, Harvard-trained physician, Dr. Joe Ladapo. I have called for the vaccines to be removed from the market in the U.S. Senate 2 years ago, and in the U.S. House of Representatives, and in the European Parliament, in the lower House of Commons in England, and in the Brazilian Senate chamber. There are calls all over the world to pull the COVID-19 vaccines off the market, all of them. They're not safe for human use. I published an op-ed in The Hill in August of 2020, and it was titled "The Great Gamble of the COVID-19 Vaccine Development Program." You're looking at the only public figure in writing who questioned these vaccines ahead of time. I did it because I saw things clearly. Others didn't. There wasn't a single chief of medicine, not a single professor of medicine who questioned these. Not one. You should be asking yourself why. How could people be so entranced? How could they be kind of caught in this deception? Many of them quietly regret taking the vaccines. I know they do. How did it all happen? I think it was driven out of fear. I think there was a coordinated messaging campaign, and then it quickly became coercive. People were forced to do things they don't want to do. And once the vaccine is in their body, they can't get it out. They know it's a committed step. This can never happen again. We're told disease X is coming, another pandemic. Anthony Fauci, our former NIAID director, who's still very active and on committees at the WHO, is saying this is going to happen. Tedros, who's in charge of the WHO, says it's going to happen. The World Economic Forum had major sessions on disease X. And then CEPI, the Coalition for Epidemic Preparedness and Innovation, that the World Economic Forum and the Gates Foundation founded, has a major white paper on disease X. They say it's going to happen. They're going to have another pandemic, and they've already said it's going to be 20 times more deadly than COVID. Why are all these international organizations publicly saying there's going to be another pandemic? Because there are biolabs all over the world working on creating more dangerous and more infectious microbes, viruses being the lead. The experts believe the next pandemic will happen, and it will be another respiratory disease. What are you going to do? I tell you what I'm going to do is I'm going to be ready. I'm not going to listen or wait for the government to tell me what to do. And I'm certainly not going to wait at home and wait to be hospitalized. Everybody must take action now. Be ready. Be ready to critically evaluate what's going on, question what you're being told, and use your common sense. Take care of yourself, take care of your family member, and take care of your country. You better message every single person you plan on voting for, and you better tell them about this, including the people at the top. Because they need to be woken up if they're still asleep. If they're actually in on this, it's even worse. I can't believe that our two major presidential candidates don't know about the safety problems with the vaccines. I can't believe that they would not understand that approximately 550,000 Americans have died after the vaccine. That roughly 1.2 million people died with COVID, of which maybe 10% really would be adjudicated as COVID. These are large losses of life. This is greater than the Civil War. This is greater than our World War II losses. And yet they're talking about other things. The media is talking about other things. Only you can wake people up. Only you can speak out. It's pretty clear we're not going to be saved by the next presidential candidate. We're not going to be saved by another senator or congressman. We've got to save ourselves. I'm Dr. Peter McCullough. Thank you.
Thank you, Dr. McCullough. Representative Montenegro, some closing comments?
Sure. Thank you, Senator Shamp. I want to, first of all, start by thanking you. I was only able to catch half presently here. I was listening online as I was driving here. But the reason I find this to be so important, and again, I want to thank you for your heart, Janae.
Thanks.
Because the way that this is continuing to be brought forward, I know how important it is. And I know that what's in your heart as well to do this. And frankly, I'm in the same boat. I want to thank also Dr. McCullough and the rest of the distinguished panel of doctors and speakers today, because the reason I'm not an expert in health, that's not my expertise and forte, but I've decided to educate myself. And I also believe that one of the most powerful things that we can recognize is that this country, the United States of America, is the foundation of it is built on individual rights, the power of those rights that we have been given by our Creator. And I love that American spirit of rebellion, that rebel spirit where we refuse to be told what to do. We refuse to be led to the slaughter like lambs. We refuse to just sit by and let our loved ones be affected. And that's the spirit of what happened here. That's really what happened. That's what's happened here, at least more evidently the last few years. And as stewards here in Arizona, we can only be stewards where the people and the good Lord have placed us today. And that is in the state of Arizona. And I think that the most powerful thing we can do is, one, respect the Constitution, respect the power for individual rights, respect the ability for people to inform themselves, and to aid or enable or fuel that flow of information. That's what's so powerful about this. Everybody keeps saying, trust the science. And wow, I'm so glad I am trusting the science. As we allow that to flow, Arizona is one of the states that has really been strong in pushing, for example, initiatives like right to choose in the areas of medicine. And so we're going to keep sounding this alarm. And I just want to thank, again, Dr. McCullough, thank you for giving so much of yourself and giving so much to the American public and the world, frankly, to information to educate themselves and to be able to make decisions that are going to best suit them and their medical needs and their family. And so the one thing I'll say last and finish is we have to be able to have as much options, as many options possible, as much information to choose from as possible, because I think that that's where the wisdom is. Choose your counsel wisely. When we're dealing with your life, with the life and the health of your family ones, I think we should have as much opportunity to make those decisions. And this is what this is about. And so it'll go down in history as Arizona sounded the alarm. Arizona, thanks to Senator Shamp, thanks to the distinguished panel here, Senator Carroll, I see you here today. I didn't forget about you, sir.
Thank you.
Dr. McCullough, every one of you, because of this, history will say, look, there was a voice that was, at least a voice crying out in the wilderness, right? A voice pushing information forward so that Arizonans, whether those that are here today personally or watching us online, had the ability to hear this and then choose their counsel wisely. So for this, I am extremely grateful, and we're going to continue to do everything possible to give Arizonans the best that we can offer. Thank you.
Thank you, Representative Montenegro. Senator Carroll?
Thank you, Senator Shamp, and for allowing me to be on the committee to sit in for Senator Shamp today. Dr. McCullough, a few years ago, you gave me a book personally, and I got me started on understanding the COVID and the whole situation that we were faced with. And I would say for myself personally, as I listen to things that are brought up here and look at some of the other endeavors that I have to do down here as being a senator and also being in the House, because I work in energy production, I work in the environmental arena, I work in mining and our natural resources. I also work with some of the law enforcement aspect of things that go on in our daily lives here, our state security, national security, and there's some common threads that I hear through here. One of them is talking about government, people in government, basically, whether it's the federal government here in the United States or it's governments in other countries, and the relationships they have with private business. And there seems to be collusion, leading to coercion, and as mentioned in this committee here, the substitution of who really are the experts in any endeavor, but in this case the medical arena, being blocked out from the public to do their service with the public and allowing free speech, free thinking, freedom of choice. And it's a problem, and it's something we have to endeavor to fight. We also have the United Nations, which was barely mentioned in here just briefly, or some of its agencies, and that's a big problem. I've always advocated the United States should get the hell out of it, okay, because it is a challenge coordinating through that. And of course, the other mention here is our adversary, the People's Republic of China, the communist government that exists there. And that is our number one adversary, our number one threat. And unfortunately, we rely on them considerably for a number of things, whether it's our medical products, whether it's our energy production products, whether it's anything else that's here. And it's most unfortunate that they have us in a box. We have us in a situation. And when I listen to some of my sources that I deal with national security and so on, all those areas, we're faced with a situation, as Dr. McCullough mentioned about the threat of a worse virus. This is biological warfare as long as I'm concerned. I was called a racist for bringing it up early on in my endeavors to get into office. Even though my mother's Chinese, I guess it doesn't matter. If you say the magic word, you're a racist. So that's how it goes. But I will work diligently in my part, my oath office, to fight this, whatever it takes. And we got a long road here. So I'm with you all. You know, I mentioned my wife earlier. It was a real tough situation. It was I always took it as they gave her a choice. How do you want to die? You want your heart to fail, or do you want to take this shot and see if it does you in that way? And I won't ever forget that. That's one of those things. So I just briefly wrap it up by saying, I signed the pledge. If you don't know what's in the pledge, here's the words. I hereby pledge that as an elected official, I will oppose any government action and repeal/veto any law that would coerce or require any American to acquiesce to a medical product or procedure. My signature, my word. I will stand with them. Thank you again.
Thank you, Senator Carroll. I was very honored to sign that pledge myself. You know, I think I sit up here and I do the work to bring these people together, and I'm so grateful to you all for being willing to come here and for staying in this fight, because it's at a personal cost, and I know that. I will never stop being an advocate for my patients. And I went from having one patient at a time to having all of you. And I don't take that lightly. I will always be a patient advocate. I will always stand. People hear me say this all the time: right is right and wrong is wrong. And we have the right to question. And I agree, the American spirit is powerful. Green Mountain Boys, Ethan Allen, thank you very much. Thank you. This crisis that we're in, I believe the only way out of it is for us to educate ourselves and for us to educate others. Not one more person should die in the hospital from the protocols that they're currently using. Remdesivir needs to be gone. It needs to be gone. We need to make sure that what we're doing is good science, healthy science. And mark my words, I will not rest. The documentation is there. We know about the reimbursements. The time is coming. And I will not rest. We will continue to do these committee hearings. We will continue to talk about it. We will continue to put this information out there. And I will help continue to put the calls out. Do not get a COVID-19 vaccine. And we will eventually come together. And we will get it pulled from the market. We won't stop fighting for it because we can't. Because as long as we stop talking about it, if we want to put our heads in the sand and we want to just forget about it, I can't tell you how many times I've heard that, then Disease X does win, and it will come. We can't forget that there was a patent for this in 2015. We can't forget they talked about this in Event 201. We can't forget that. We cannot let them gaslight us. We cannot let that information be scrubbed from the internet. We have to continue to talk about it. We have to continue to move forward, and we do it together, united. And we do that as Americans. We do that as Arizonans. We do that as friends, family. We do that with our hearts. And we share. And we continue, no matter how aggravating, no matter how painful. Because it is. It's frustrating. But we can do it. We've overcome much worse as Americans. So with that, I say thank you to everyone who's here today and everyone who's watching online. Stand strong. Stick together. And we will win through this. Thank you all for being here. We will have another hearing, and of course it will be announced probably about a month prior to it getting put together. And with that, there is no other business, and we are adjourned.